Meeting now, which is the 150th meeting of the Board of Directors of Oxleas NHS Foundation Trust, not as the agenda says, which is we were hoping for a face-to-face, but for advice reasons and changes in guidance, we're now going to meet on Teams. I sincerely hope that it won't be too long before we can all meet again in person. So welcome everyone. We go to item 1 on the agenda, which is apologies for absence. Sally?
With apologies from Amlan Basu and Jane Wells.
Thank you very much. Any declarations of conflicts of interest from anyone? People, if not raise them now, they can raise them as we go through. Steve, I'm just looking at my screen. Is your mentee here?
I can't see her yet, but I'm. Oh yes, I can. Yeah, Ashantel. I could just see she just turned up. So Ashantel Lakhani is joining us today. She's on a NHS scheme about people who want to be NEDs. So welcome to her.
Big welcome, Ashantel. We were discussing earlier that you might be able to give a sort of feedback to Steve about our board. As well as the LGT board for lessons for us to learn from partners. So you're very, very welcome. Thank you. Good to see service directors here as well. and something that certainly I would like us to do more of in the future, so that it will be absolutely vital for the delivery of service. And I think it's not only good to hear from you, but also for you to be party to the various discussions that we're having. If we move on to the minutes of the last meeting, people, then we'll just sing out as we go through for page 1, and then page 2, page 3, page 4, 5, 6, 7.
Andy, it's Jo.
Hi, Jo.
Right, just on page 7 on the business committee, I wasn't at the last meeting. Had I been, I would have presented the report from the business committee and said all those things, but I wasn't there. So I suspect it was either Steve or Azra. And just to say, on the third line, I presume that COVID 169, unless something has really taken off that I don't know about, I presume that should be COVID-19.
Okay, thanks, Jo. Azra.
Sorry, Andy, I had some other corrections on that, which I have separately sent to Sue, but unfortunately wasn't able to get in before the minutes were sent out. Joe picked up one. Can we change the word monies to funding in? And then basically that sentence should read funding in line with South East London ICS policy. This is the key driver for the in-month deficit.
Okay.
And then also under the infrastructure committee, also on page 7, 1, 2, 3, 4th line down, where we say AM is reviewing the advice. If advice could be changed to current draft ICS guidance.
Okay, if those are happy with that. Thank you, Ezra. Suzanne?
Sorry, Andy, my buttons are working a bit slowly today. It's just in relation to page 4. I have already advised Sue of a requested change, but it says that we'll be reviewing the whole pathway. That should be the harmed patient pathway.
Okay, thank you. That's page 7, page 8. If not, thank you very much. Any matters arising from that are not in the rest of the papers? And if not, we'll go to the board assurance framework. This is something I do want to spend a little time on, just to make sure we've covered this. We did this, I think, back in July. So there's an opportunity for us again to go over this to make sure that we have that board assurance. Iffy, you're going to take us through these.
Yes, thank you, Andy. Thanks a lot for that. So as board members know, we have 16 risks on our board assurance framework, and each risk is owned by a subcommittee of the board. Steve, get your hand up.
No, sorry.
No, I saw Steve Cook's hand go up.
Oh, right, sorry.
No. Okay, my apologies. I'm sure I saw his hand go up. So what we have in the papers today is the latest board assurance framework since our last board meeting. And I'm glad and indeed grateful to exec colleagues and NED chairs of the respective subcommittees for all the work they've done to ensure that the risks, controls, and mitigations are well defined and described. As I'm sure you would have seen, the longest risk on our BAF is demand on CMHTs, having been on the BAF for 21 months. And clearly, PQAT take the view that it should remain. We have 2 new risks, both of which are less than a month old. ICS capital regime, which has been talked about quite a bit at both infrastructure and business committee, and one that the partnership committee added a few weeks ago, which is about the uncertainties created by move to the ICS approach. So we have also linked our BAF to our trust strategy. You'll find that on page 20 of the bundle. And finally, as the front sheet shows, we have 3 significant risks and 10 high risks. And if it's okay, I'll ask Chair that the exec leads and the NED leads of each of the board committees take it in turn to say a thing or two about the high and significant risks that the respective committees oversee. As just one final comment before I pass on to Ian and Yemisi, you'll see that health and safety, quality improvement and innovation, as well as audit and risk committee do not have any risks. And so I'll hand over to Ian and Yemisi to take us through the significant and the high risks in PQAC, and then take it in turn as outlined in the front sheet, business committee, partnership, etc. Ian.
Thanks very much, Ife. So I'm very happy to take the board through the risks that are owned by PQAC, and I'm sure Yemisi will add anything that I've forgotten. So as it sets out on the front sheet, currently PQAC have one significant risk, which Ife's already alluded to, and 3 high risks. In terms of the significant risk, this relates to waiting times across all of our community services. The board will be aware that a focus on waits and, more importantly, on delays is now a significant part of our kind of strategic work, currently being led by Lorraine. One of the points I wanted to highlight for the board is that what we are trying to work on alongside the work to try and reduce waits is around visibility. So the Performance and Quality Assurance Committee has heard from myself and Alison around a piece of work to revise the IBR. Part of that work will be really to kind of have much greater line of sight for the subcommittee and therefore the board as to what our significant weights are. So I think that will really improve our ability to kind of understand the mitigations. But essentially, across all of our community services, the issues remain around demand and capacity. Where we are getting investment, we are targeting that investment to improve capacity. Alongside that, we are trialling different ways of working to try and meet demand. And if you may want to say more about that when he talks about weights in the chief exec reports. And then I think the other point, given what we know about the context of the delivery of community services and the importance of place, I think across all our service lines, we're really trying to think about how demands on our community services are thought about systemically and looking at opportunities to kind of flow the demand, route the demand to different ways so that people continue to get their needs met, but not necessarily through Oxleas. So I think this is a big piece of work. I think it will remain a high risk for some time, given the uncertainty of COVID and the fact that that has had a massive impact on demand. In terms of the 3 high risks, one of these is a significant quality concern, which is around reducing prone restraint. In terms of controls around this, the committee look at data around this each month. I think there is a clear line of sight around what our baseline is and where we want to get to in terms of a trajectory. I think there is real clarity on the mitigation, and that the most significant mitigation is around the trialling of the impact of safety pods, which is something that we're keeping a close eye on. The other 2 high risks are linked in some ways, I think, to the significant one around waiting times. So Ife has already mentioned that one of these is around demand on community mental health teams. It is our longest standing risk on the BAF. As I've already said, we have had significant investment through MIS, and we are looking to target that to try and reduce demand. But again, as I've already said, a lot of this is around the context of how these teams work at place. And so alongside that, we are looking to collaborate with other organisations to see how demand can be met in new and creative ways. And when I say system partners, I mean primary care and the third sector. And we are trialling a number of new roles to support that endeavour. In terms of kind of opportunities to kind of have better line of sight over this risk, we have obviously moved recently to service lines, and this provides a much clearer line of sight across our 3 boroughs, and an opportunity really to kind of share good practice and to look at a standardisation in the way that we approach this as an issue. And then the last risk is specific to district nursing. This has been on the risk register now for the BAF for about a year. Unlike mental health, we haven't seen the same level of investment into community health services, but we have staggered investment going into district nursing over the next 2 years. Of course, like community mental health, money is great, but it's about availability of staffing, and that is a limiting factor in terms of how we might use that money. Because we've moved to service lines, the directorate, the Community Physical Health Directorate, is now able to look across both Greenwich and Bexley. The issues are slightly different between the 2 boroughs, and I think this is, as a risk, is more profoundly felt within Bexley than Greenwich. And the directorate are looking to review both sets of services. And again, it's around opportunities to do things differently internally, but also have that conversation at place level around how demand can be met in slightly different ways. And of course, as I've already said, both of these latter 2 risks are very much in part of an integral part of both the Great Out of Hospital Care and Zero Delay strategic work. So I will finish there. Yemisi, I don't know if you want to add anything more.
I think just to say, your summary was very comprehensive, and just to assure the board that we are constantly reviewing these mitigations that we've got in place, and then obviously monitoring the outcomes before we look to reduce the risks. We're very keen that we have all these mitigations, but obviously we have to see the outcomes first. So those have been closely monitored. Thanks.
Thank you, Ian. Thank you, Mrs. Steve James.
Thanks. Yeah, no, it was just a brief comment about the reducing prone restraint. PQAC does monitor that really very closely, because certainly I am, and I think other people are concerned about that. It was just a point that I happened to be in a presentation by SLAM a couple of days back, and in their business plan, one of the big things in their business plan is to eliminate it. And I think it will be interesting, in view of the partnership stuff that we do with them, to talk to them about what have they done, or what are they doing, and actually have they achieved it. So it's one thing to have a target, it's another one. But in one sense, I prefer their target to ours, in that the target is to eliminate it altogether. Whether they achieve it is different, but I'd be interested for us to find out what they're doing, and whether it works, to be honest, because I think probably we can be more, we can have a better target, because I mean, if the safety pods work, we might not have to restrain people in a prone way at all. So it's just, let's see what they're doing.
That's very helpful. I'll certainly speak to Jen and colleagues and see if we can plan a conversation, a meeting with SLAM colleagues on that, and we'll bring something to maybe the next PQAC or the one following that. Thank you. Okay, should we move to business committee?
Thanks, Ife. I'll start on that and then hand over to Azra. So as you can see in business committee, we've got 4 risks on the BAF. one significant, one high and two moderates. I think the key thing to highlight to the board is the different timescales or time horizons on the risk. So the two moderate risks actually are have a timescale of this financial year, and they're rated moderate, and may even go lower than that, merely because of our understanding of the likely funding arrangements and the fact that we think we can live within our means for those funding arrangements for this financial year. Clearly, you then go to the sort of financial longer, medium and longer term financial sustainability, where there is much more uncertainty. We know that coming into the pandemic, we had a big job to do in terms of achieving efficiencies, and we know that is looming on the horizon as well. So that's why that is significant. And then you can see bed management connected with other initiatives going on, and the work that we are doing on understanding flow and great out of hospital care as well. We hope that we'll be able to reduce that risk as we move into the next financial year. So that's sort of just an overview of and highlighting that sort of time horizon. Azra, do you want to pick up some more detail?
Thank you. So I thought the significant and the high risk that we've got, and both of was already pointed out, are the ones that have a longer time scale than the end of this financial year. So in regards to the financial sustainability of the term, this is a 2 to 3 year plan that we're looking at when we're scanning this. It's recognising that over the course of the last 2 years, funding and that additional non-recurring, we haven't done the kind of core annual work we would normally do on the generation of recurrent cost improvement plans, because we've been concentrating on actually delivering what on our services in the pandemic period. So there are two aspects that we're going to need to focus on in that future generation and delivery. Cost improvement plans are 6, and the second, contribution of all of our services via productivity, or actually in some of the new bids that we've got, ensuring that we've got sufficient headroom for head targets. And the reason that this is still significant is that pipeline of recurrent SIPs generated to date. Just a reminder, the pandemic period, that we had non-recurrent aspects that we were mitigating of about £30 million. Over the course of the last 2 years, that's probably risen to now, I would say, £1 million, and that is over the course of the next 2 to 3 years. This is going to be very dependent on exactly what we get as a 23 settlement in regards to overarching guidelines for planning, etc. We do not expect that to be a cliff edge, so we don't expect to have to go back to pre-pandemic levels and deliver 15 million in 1 year. There should be a phased approach to that, but we can't as yet determine exactly what that looks like. We're expecting more or less flat cash, and broadly, but this could change, about 3% or contribution for 22-23. In terms of the other next highest risk was the bed management. This is the other one that actually does exceed past the end of this financial year. So we've currently got a target in there of June 22 to be able to exit certainly the block booking requirements that we've got for Hayes Priory. And also furthermore, to be working through a range of different tactics to be able to address flow, and we've articulated those within the paper. So there are 3 areas that we're going to be effectively working on. One is around a better understanding of staff around the supported accommodation pathways, i.e. exactly how you would be able to discharge patients, but also actually think through upfront avoidance of actually admittance. operational rigour on the ward, which is effectively around length of stay and flow as we're coming through the hospital, and the patient flow hub, which effectively manages our acute entry point from our A&E and then does the allocation of beds. We do think that with a combination of that and the new directorate structures and the introduction of a new flow director that will be starting in January, that we have got the building blocks to be able to actually meet that target. I have to say it's probably not going to result in the complete elimination of all private beds at June 22, but just as a reminder, when we went into this position pre-pandemic, we were using somewhere in the region of 3,200 occupied bed days on acute crisis when we had both of our 2 wards open. So it's trying to significantly reduce that and completely exit out of the Priory, Hayes Grove block booking arrangements we currently have. Moving through then some of the, so 198 East and ICS financial risk, both revenue and capital. As we move on to the infrastructure committee, we may be separating out capital risk, and that distinct difference, we think, in the funding allocation and the pressures that we will have on revenue. We're expecting capital to be far, far more stretched. For this financial year, because we've had settlement in H1, we've had a good capital settlement that's actually addressed everything that we wanted to do. And for revenue, we've already exited with carried forward some funds for H2. H2, we have received a funding envelope that we think will effectively deliver a break-even for H2. So we're confident about the revenue. The capital, as I said, will be fine for this year. We may have some issues about needing to rejig exactly which plans are put in place and which projects we deliver this financial year. Then moving on to the next and final risk highlighted is that's for integrated and embedded services. And this was really around the fact that for a number of our local authorities, we've embedded the profile of staff that we've got working through those areas. And we have got an issue with the fact that those that are employed by ourselves effectively get an Agenda for Change pay uplift. That has been covered and addressed over the whole of the pandemic period. And therefore that risk we've still said is moderate because there's still, given the pressures that we've got within the local authority funding, there is still the possibility of them coming back to us because they usually set their plans for future years round about December time, for them to come back to us this financial year to say that they are looking for additional SIPs or an additional requirement for savings that we would need to address. I think probably once we could move to a lower rating, but those final deadlines do so. That was going to be run through. I don't know if there were any questions.
Thank you, Azra. That's really very detailed. And thanks a lot, Joe. Are there any questions for Azra? I don't see any hands. So I'll just pick up the partnership committee very quickly, if that's okay with you, Joe, but you're of course welcome to come back in. So this risk we rated high, which is essentially about our capacity to respond as the ICS unfolds, and also our ability to influence the development. So of course, board members know that we invited the ICS leadership to speak to us at the Board Away Day. That was just about us being better informed, and I'll continue along with Andy and others to influence and shape where we get to. And at the partnership committee, we invited Bexley, and we will in turn invite Bromley and Greenwich. And I'm really delighted to say, although this is also in my report, that on the back of Bexley's attendance and our feedback to them, they have now accepted our request to have two separate people, albeit from Oxleas, one representing mental health and the other representing community health. So we will continue to engage in the conversation. I think that there might be an issue about our leadership team being stretched. As you can imagine, sitting at the ICS partnership and board, and then sitting in the respective provider collaboratives or networks, and also at place. And all too often, as I've said, with Bexley, you've got someone for mental health, someone for community, and then we'll have a number of other groups, transformation boards, where we have also senior leaders involved. So we will continue to do our best such that by the time we get to March, April, we'll be in a good position to hopefully streamline, but at least to have influenced the direction for the next financial year. That's all I wanted to say, but I'm not sure. Jo.
Yeah, thanks, Ify. I think that's great, and well done in terms of getting that extra seat at the table at Bexley. I think all I wanted to say was, so this was a risk we raised on the back of the last partnership committee meeting. I think as we go through this financial year, and I suspect into next financial year, we will this risk will develop in ways that we can't be that specific about at the moment, but I think it's an evolving risk which we can add more detail to as more detail becomes clear. But there are, as we all know, and I saw Andy sent out another couple of things this morning on the ICS, there are a lot of moving parts and some quite fixed timescales. So making sure that we can be across all that is, I think, quite a stress for the organisation, but it is really important.
Thank you, Jo. Are there any questions for Jo for me? No. Infrastructure.
I think we're going to start with Alison on this.
Yes, thank you. Yeah, I was just going to talk through the cybersecurity risks. So the cybersecurity risk, really, we've got a number of cybersecurity risks on our risk register, and obviously the risks related to cyber change over time, and they're constantly under review by us in the organisation. And that's certainly, you know, within the IT domain, one of our key areas of focus. I think the reason for raising the risk to the BAF is in part due to that ever-growing risk that we see, and that's especially true since COVID. And also, I think there's more of a concern, particularly in healthcare settings, that healthcare settings are being targeted for the data that we hold. And there was a briefing in the summer to CEOs, and I think Ify also went to that briefing at the time, highlighting that ever-evolving risk. And there was a recommendation that organisations consider whether cybersecurity should be on their BAF. So we had a good discussion about our cyber risks at the Infrastructure Committee, and we've created a BAF risk. But I think for everyone probably on this call, understanding the risks related to cybersecurity is probably a bit tricky. And I think even for myself as well, when I first came into this post, understanding our approach to cybersecurity was quite hard to get my head around, and the head of IT at the time gave me a great analogy about cybersecurity, and he said, you know, it's like an onion. There are many layers to cybersecurity. You have to peel them and make sure there's proper security at every level, and that's what we do in the organisation. So there are a number of things that we do in terms of focusing on the systems that we have in place to ensure that we're protected as it can be. We also focus on the policies and the procedures for our IT staff to kind of manage that IT risk that we have. And there are training and communications that we send out to staff, and we ask staff to participate in during the year. But I think the real risk to the organisation is one that it's actually just quite hard to control, and that's that zero-day risk. So that's that a new bit of software or a new vulnerability is made available and strikes an organisation, and it's something that we didn't know about. So it's a new vulnerability. So that is obviously the ongoing risk. But having all those layers in the onion that I talked about earlier put us in the best place that we possibly can be, so that when things like WannaCry happen, which is a vulnerability that hit the NHS back in 2017, you know, we're prepared as we can be. Unfortunately, in that incident, that didn't affect Oxleas. And I think also since that time, the NHS Digital have upped their game in terms of the protection and the support that they provide to NHS organisations through something called ATP, which is Advanced Threat Protection. And they basically monitor every computer across the NHS which are linked up to ATP, and they will notify us if they see any activity that we need to be aware of. And we saw actually that in action very recently, where we were trying out some new technology to break passwords, so some threat protection that we were looking at internally. And I got a call from NHS Digital saying what's going on within a couple of hours of us doing that. So, I mean, the threat is really, as I say, it's constantly evolving. There are a number of things that we do internally, and we're obviously constantly changing the way that we approach this. But it is an ever-evolving threat, and I think it's right to have it on the BAF. It may be that we want to provide more training for, certainly people on this call to just understand that threat in a bit more detail. I think in the longer term, we will need to consider whether or not that is a threat that we manage and tolerate, or whether or not it's something that sits on the BAF for a long period of time, but people are aware of the mitigations that we're putting in place.
Thank you very much for that, Alison. I don't know if there are any questions for Alison before we go to the next risk, 1995. No, okay, thank you.
Okay, shall I go? Oh, sorry.
Oh, hang on, Stephen Dilworth, please.
Yeah, thanks, Iffy. I wasn't quite sure if Suzanne wanted to come in there, but I'd just quickly say, as Alison's correctly touched on, you look at someone like the CIA, who've got the biggest, using Alison's analogy, biggest layered onion in the world, and they got hacked. So it's very much not a question just about protection, because at some stage it could happen to anyone. It's how you prepare for it. But it was good to hear Alison commenting on, the preparatory work as well. And certainly, as Suzanne and I have both had conversations with Alison and Lee Christie about the protection we have. But the one thing I think from a board perspective in our mitigations, it would be good practice that once a year the security information officer or the information officer, basically Alison, attends a board meeting. So this would be in addition to the infrastructure oversight. And we have a discrete separate item on cyber security. And I think that is now fairly common practice elsewhere. So that's something we should have, and just to include it in our mitigations. It just ensures that you've got that broader board oversight. Thank you.
Thank you, Stephen. I think we have talked, certainly Alison and I have talked about whether this should be something we do at one of our strategic board meetings, and perhaps we could take it outside of the meeting and consider with Andy and Sally. Thank you. Andy?
Yeah, just on that last point, if we have our strategic meetings, of course, it's not a minuted meeting. And I think, Stephen, you were saying that this should be a presentation to the board, should it not, on cybersecurity?
Yes, should be to the board. And as you rightly say, I think from a external point of view, and bear in mind, we're being watched by regulators on this as well, it does need to be minuted. And also, of course, it allows appropriate questions from across the non-exec range. But yeah, I think it should be at least minuted, whether that's easier done at a formal board meeting. But alternatively, we could do it in an away day, but make sure that we make a minute of that presentation.
Okay, I see a few hands. Alison and then Sally wants to comment on this too.
Yeah, I mean, I guess in terms of thinking about that strategic away day, I wonder whether or not the National Security Centre provide training on cybersecurity, and we could provide that for board members at an away day. And I think at the moment we do provide an update to the infrastructure committee that gets noted at board once a year around information governance and our data security toolkit. So that does happen currently, but happy to put more of a focus on cybersecurity and actually take the paper at the board, as well as that going through the front sheet and Suzanne's update as well, if that would be useful.
Yeah, and by the way, I do appreciate that we already have that bit of the process. So what I'm suggesting is a little bit more.
Yeah, sure.
Sally, do you have anything to contribute to this in terms of formal board
just
presentation?
If it's an assurance aspect, it should be at a formal board, and I would agree with Alison's proposal that it's using that regular report, but having a particular focus and section on this, and we can have it as a separate item if that's what the board would like. If it's something more strategic, working through what we need to do in place or training, then that's perfect for the away days, and Alison and I can link on that and we can plan that for a future one. Thank you.
Sure, I see your hand is up. Do you want to come back in and take the reins? Or?
Yeah, only just to say that I think that an action from here then, that we will need a formal presentation at some stage or other to the board. So we need to get that in as an action, and at some stage or other we need a rather more general one, Alison, at one of our strategic away days. Training can be done separately, but online, no doubt. And interestingly, Sue Sauter from the Council of Governors raised this as a governance question beforehand as well. So we have to think about the governance on that. So just so we notice in an action, so we do get this as a board paper, please. Thank you.
Okay, we'll take those away. Thank you, Andy. So Rachel, I think you've been itching to come in.
Thank you, Iffy. Board members can't have failed to notice that this particular issue around carbon zero or net carbon zero has got worldwide attention at the moment, quite rightly. We've rated this as a high risk and escalated it to the BAF because the challenge that the NHS has set to reach carbon zero by 2032 is a significant one. For a number of reasons, I guess, the place where the technology is at the moment makes that difficult to achieve, but also the amount of capital investment that we'll need to undertake in order to achieve net zero is constrained by the next risk that we'll be talking about. And in addition, it needs a really wide, trust-wide focus on the actions that are required to achieve it. This is not just an estates issue. Whilst there's been significant work undertaken within estates, the green plan that is in development at the moment, and which will come to infrastructure in December and then to the board again in January, will really need to focus on everything about our organisation, from our models of care to how we procure to how our boilers are set up. So it's a wide-ranging issue. The green plan, as I say, is under development at the moment, and I would expect us to come back and have a much broader conversation about this when it comes to the board in January. I think Suzanne might want to add to that.
Yeah, thanks, Rachel. If I could just add a little bit of that to that for the sort of benefit of the broader board members. We have been talking a little bit about the the commitment to net zero carbon as a risk for some time, and I just wanted to suggest that I think that there are three things or a number of things that we really ought to be conscious of here. The first is that I don't think that we're currently well sighted as a trust on the impact that climate change may have on our population's health. So great GSTT, for example, are very clear that when the air quality in London is poor, they have an influx of young people into their emergency department with respiratory difficulties. I think that we need to be really clear as a trust about the impact that climate change has on our population's health and recognise that that's a significant factor to ensure that we really get behind this commitment to net zero carbon. I think the other point that becomes immediately apparent if we start looking at the concerns that GSTT has, for example, is that poor air quality isn't something that just happens in Southwark. You know, we're all contributing to it, and this really is something that we need to be addressing at system level. You know, the ICS is a start. My own view is that there really does need to be a pan-London approach to this, but I was pleased to hear from Rachel when we talked about this recently that her team is already in touch with a team at the South East London ICS that's bringing together some of the leads from other trusts. I do feel quite strongly that GSTT has a whole team working on this. Rachel has, you know, 0.5 of somebody's time and a whole set of willing volunteers. But I think that we probably ought to be persuading the ICS to share the resource, which is currently located in individual organisations. It's clearly we need to have a green plan because it's an expectation of the NHS that we commit to net zero carbon. And so that's a reason to do it, you know, to play our part in that. There's obviously a moral argument as well that we really need to play our part in this. But fundamentally, this is not about just delivering a green plan. It really is about changing our operations. And I just wanted to reinforce the point that Rachel made, that this isn't just an estates issue. This goes right across the piece. You know, we had a conversation yesterday about whether we know what the carbon contribution of providing community-based services is, because we're asking people to go there in petrol-driven cars at the moment. So we really do need to do quite a lot of work to understand the way in which, you know, as a provider, we have a certain carbon footprint, and some of the ways in which we might reduce that could well be to have to shift some of our service offer and to think about how we do it in a less carbon intensive way.
Thank you, Suzanne. Stephen Dilworth.
Yeah, thanks, Sophie. Well, first of all, thanks to Dan who has championed this, and it was Suzanne who was first pushing for this to be on the BAF, and also for Rachel for the work she's done. So a couple of things I want to mention. First of all, on the back of COP26, whether we like it or not, this is obviously now a huge item. As has already been said, this is across the organisation. It's not just infrastructure. It will certainly affect audit and risk as well, because it will affect our overall strategy. That's got to have a piece in there, as we've touched on, about climate change. It affects our statements, it affects our policies, it affects our processes. So every subcommittee, every member of staff in some way has to be thinking about this particular item. And just to give people examples, going forward, certainly companies outside, we're not quite sure how it affects public organisations, will be having to make in their annual report and accounts or annual statements 11 additional disclosures, all on climate change. And 11 doesn't sound like a big number, but when you drill down a little bit on that, the work that goes into, as Sally will know on the annual statements, the work that goes into just having one additional statement is huge, because there's a lot of data involved. And in terms of data, we will get pushed. There'll be NHS, our regulators, there'll be the government, but even on a financial aspect, the Financial Reporting Council, they've commented on the metrics. Suzanne was just talking about sort of measurement of our carbon zero, because as the FRC is saying, the metrics on climate change are really poor at a sort of organisational level, which they are. I don't know what metrics we've got, but we won't. I don't think we'll have many in terms of measuring our own carbon footprint. So that will be developing, and it was interesting, I think, for someone like the Financial Reporting Council to be commenting on that. So that's what they're looking forward. That's what they're encouraging organisations and external auditors to be picking up on, and we'll see that by the end of this year. For our financial reports 21-22, we'll start to see some action on that. So it's really, really important that we all embrace this. got to be embraced at a board level. As I say, it'll be certainly a big piece for audit and risk going forward, and that'll be of interest to the governors, because I've asked our external auditors, Grant Thornton, to just give an initial comment from their own perspective at our next audit and risk meeting, and I think Sue, the lead governor, will be at that meeting. So this will be a huge item. The other thing I would say is the risk will change. We don't want it on there for 12 years in this current format. That then doesn't become a risk. It becomes just business as usual. So we'll have to be mindful of we develop that risk. As Rachel will know, particularly in the sort of technology investment point of view, I rather suspect we'll leave that for a few years, for the simple reason that technology will get better and it will get cheaper. So, you know, an investment in 2027 will be more cost effective than in that way than 2021. But as Suzanne has also pointed out, some things can't wait. That we will just have to spend the money earlier than we anticipated. But just remember that we the risk will change. So this exact risk will come off at some stage, but it will be replaced by something else on the climate change aspect with different text and different mitigations. Thank you.
Thank you, Stephen. Okay, so we've got one more from infrastructure. The significant risk.
Rachel's going to take that, aren't you?
Yeah, I'm going to start, and then I think Azra is going to follow on. Whilst this is a new risk, it's not a new discussion. We've discussed this a number of times, and this is a significant challenge for the organisation, and therefore we have rated this as a significant risk. I think it was previously linked with a finance risk around revenue, but we've separated it out into a separate capital risk, because we'd found at Infrastructure Committee that we were considering a number of risks that really all came back to the same thing, which is, were we going to be able to invest our money to address the infrastructure issues that we have going forward? I think the risks that we previously had related to ligature management expenditure, and also in relation to our ageing estate, both in terms of the physical building estate, but also in terms of the IT infrastructure. So we've brought this together into one significant risk. We're doing a significant amount of work behind the scenes to look at what our needs are over the next 5 years, so that we're in the best possible place to negotiate our position with the ICS. And we have developed 5-year capital plans that are risk rated in order to take that forward. And Azra, I think, might want to say a bit more about the interaction directly with her colleagues at the ICS in relation to this.
So just to go through the key elements that are driving this, this is about there is now an allocation that is given to South East London ICS. That allocation is effectively for replacement of current assets. It's not supposed to be for major strategic rebuilds or major strategic investments. But what's happened is some of those strategic investments have been pushed into that operational capital pot. And just to kind of highlight what the impact on the trust could be of that, last year, or this 7% of that operational cycle, that could go down to as low as 4%, depending on exactly how we negotiate that out and which elements of capital is applied in South East London and Slice. 4% would bring down our capital ability to about £8 or £9 million versus the 17.5 million that we used this year. So this is significant. And I think it's going to be driven as well by the fact that we have been very diligent in ensuring our backlog maintenance was maintained on the estate side. So we haven't got the major leaking roofs, etc., that some of our other colleagues in South East London have. And secondly, the risk to our IT infrastructure and development through the fact that we've actually heavily in agile working and in some of our infrastructure. But what we haven't had is the major IT investment that some of our acute colleagues are now effectively driving and have had internal business cases to develop. So that's just a little bit more flavour of the actual financial risk associated with this one.
Thank you, Ezra. I think that's all on infrastructure. Is there any more, or are there any questions? If not, we'll go straight to People Committee to go over their high risks.
Thanks,
Okay,
Iffy.
People
And
Committee.
hi, Iffy. I'm going to kick off and Nina will bring in anything additional at the end. So happy Diwali, everybody. We've got 3 high risks at People Committee. They've been updated because there's a lot of mitigating activity going on in this area, and we're going to have a detailed deep dive into them at the next Audit Committee and at the next People Committee. So the first high risk is the recruitment risk, which is recruitment 1213. It's a pretty constant risk for us as an NHS trust, but it does feel pretty hot at the moment, particularly as there is new funding in the system and a lot of people are competing for roles. So what we're doing is we have a dedicated recruitment hotspot role, which is working really well, actually. We're exploring international recruitment in a way we haven't done before, and there's lots of exciting activity happening in that space. We've got more than 100 apprenticeships. We're taking a much more creative approach to workforce planning and thinking really carefully, not about roles, but about tasks and how we can make sure that we make the very best use of our scarce resources. We're exploring approaches like refer a friend to see whether or not that would help in terms of recruitment, and we're bringing in some expertise on that to advise us on whether or not that would be appropriate. But also we've got a really big focus on retention, because most of all we want to retain the fantastic staff that we have now, and all of our programme of work around Great Place to Work, which I'll speak about a little bit later in the board, all speaks to that. The second risk is our discrimination and violence and abuse risk, and we know that this has a really significant effect on sickness, on morale and on recruitment. So you've heard me talk a number of times about our Building a Fairer Oxleas programme. We're now in our 2nd year of a very ambitious programme. And the plan there is now to be focusing both on the experience of our Black, Asian and minority ethnic staff, but also on other protected groups, disability, people with lived experience, mental health issues, and much more. And we're really actively engaging those networks in driving those improvements forward. But we're also looking at violence and abuse, and we've got an active group looking at this. We've got some fantastic learning from quality improvement projects, where we've seen a 40% reduction in some of our most challenged areas. So spreading the learning from that is really important. We want to build on our new values to make sure that our patients know what they can expect from us in terms of behaviours and what we can expect from our patients too. So a patient compact that we design with our patients is going to be really important. We're going to have directorate leads on violence and abuse to have an overview of the themes. And we're formalising all of our violence and abuse work so that it is a full subcommittee of People Committee, and the People Committee will have an overview of that work. The final high risk we have is our morale and burnout risk. And of course, with all that we've gone through over the last couple of years, this is a really important risk for us. It's been great to see actually how many people have been taking some breaks recently, and I think people are coming back refreshed, having been able to have a proper break. And so really, we're really encouraging people who haven't yet had a proper break since all of the pressures of the last 18 months to try and take the time to do that, because that's clearly very important. We've got wellbeing champions going to be in place right across the organisation, launching in December. There'll be a source of resource about signposting where you go to for support, and there are some fantastic things out there. So Keeping Well in South East London is a really good resource where you can access professional support as a health and social care member, something that people who've been using have found really useful. We've been improving our approach to agile working. We're investing in our frontline managers with our Oxleas programme that we've launched in the last week or two. We've got mental health first aiders, and there's a brilliant package of support that we're going to be having on the Ox. Governors have raised questions about this because we know that it's really important that that we get this right, and the risks of people leaving and turnover is considerable at the moment. The question that the governors raised, I think, was around our nurses, and I know that Jane can't be with us today, but she would want to highlight the great work that they've been doing around creating action learning sets for our ward managers and also around our preceptorship scheme. But we also want to do things like our staff recognition awards to try and bring a bit of recognition, but also a bit of fun and a bit of joy to the work that we do. That's all I was going to say, Iffy, but very happy to take questions. Nina, I didn't know if you wanted to come in.
Thank you, Rachel.
I don't have anything of substance to add. Rachel, as always, has covered it very comprehensively. I think there are some interesting points of detail that we can go to later with the report from the most recent People Committee that will expand on some of the things that Rachel has said, in particular the joiners and leavers data and the pulse survey.
Thank you, Nina. Thank you, Rachel. Andy, that's the end of the agenda item. Shall I hand back to you?
Thanks very much, Iffy. Are there any other questions on anything else to do with board assurance? Stephen, please.
Yeah, thanks, Andy. It's a very quick point, just for information, that we're now at 16 risks on the board assurance framework, and mindful of the mid-staffs issue of a few years ago where they couldn't see, in their words, couldn't see the wood for the trees. They had too much information. So Grant Thornton's recommendation in terms of the size of the bath is that it should be with a scale of maybe up to 15. So just to give you a heads up that we are slightly outside that. I'm not going to get too hung up about that. I don't think we will do. And neither will the external auditors. You know, they won't worry that we're just outside the recommended scale. But I think it's just a guidance for us that we're probably, in terms of items on the BAF, as far as we would want to go. And if we could get one or two that come off, perhaps are tolerated, that would be helpful. But the key thing is we don't really want to lose focus by adding to the that number that we've currently got, because you know there comes a point where you can't really focus properly on the actions that you've got to take. So it's just for our general advice and the governor observers to be mindful of that.
Yeah, thank you, Stephen. I think it's a really good point. I was also thinking about the accompanying pages that come with this, which are very helpful. There's a lot of detail in there. But I suppose the question I was asking now, and we don't need to answer it now, but do we need those following pages in the board papers? Given that you, Stephen, through audit and risk, will no doubt look closely at all of those in the detail. And the question I pose back to the exec is, do we need those extra pages with detail? Because I found this discussion on the BAF very helpful. I think it's what the board should be doing at strategic level. These are the major risks, the ones we should spend time talking about. I just would like, it would be helpful perhaps if we could reduce the number of pages as far as that item is concerned. If we move on now then, thanks so much for that, to UFE, the Chief Exec report, given that we've covered quite a few, and when it goes from when we talk to Ian, a lot of the really important things have been discussed, but over to you. Thank you.
Thank you, Chair. You're absolutely right. A lot of things in my report have been discussed, and therefore I'll try my absolute best to be very brief. Just to say that board members would have noticed this is a new style Chief Exec report in response to the ask of net directors, and I'm grateful to Sally, service directors, and my exec colleagues for helping develop this. Of course, this is the first iteration, and I'm sure we'll continue to improve it as time progresses. Just a few key things that I want to mention. Really delighted with the appointment of Tom Cahill. I often think of people with learning disability and autism as really disadvantaged, and we need to make sure that nationally, certainly within the trust and locally across South East London, that we maintain that focus. And I have no doubt that Tom Cahill will ensure that. I think too that it's important to for the board to note a minute the sad news of the death of James Brokenshire, who was really a supporter of Oxleas, particularly our work at Queen Mary's Hospital. And we did as a trust send our condolences to his family. I don't intend to say anything about the ICS because we already touched on that. The COVID update remains broadly the same, and our vaccination programs, both for the booster and flu, are ongoing. And you will see in Ian's report further information about our involvement in the 12 to 15s vaccination program. It is interesting that compulsory or mandatory COVID vaccination will become the norm come April 2022, or 1.2 million NHS staff. And so I think that we will have to start thinking very seriously about how we achieve this by the next financial year. Lorraine pointed out, and I'm just drawing this out in her report, as you know, local authority staff are expected by, I think it's the 10th, to be fully vaccinated. And we have 5, as I gather, in Greenwich who are in the final process of their contract termination. The performance overview, the only thing to draw attention to, which is of real concern, and we've talked at length about this, it's in our BAF, is of course our waiting times. You know, as you will see, it's a combination of not just being able to recruit, because we've been able to attract additional funding to help us, but also as a result of an increase in demand. And sadly, for some of those teams, not all of them, for some of those teams, we've had chronic underfunding. And so those 3 things have come together to put us in this position. But we're determined to prioritize this. You do, of course, know that zero delays is one of our strategic objectives. And we're definitely going to work on this. And the board will no doubt continue to receive reports about this. I can't but thank Richard, Claire, and colleagues regarding the successful shadow executive. It was really quite pleasing to read the feedback of the current cohort. We're just about to go into recruiting the next cohort. And then quite a number of events, Black History Month last month, and many other events, the details of which are on our intranet. And then finally, because this really matters to me, I'm really delighted that we're about to launch our leadership program. We preluded that with a compassionate leadership event with Professor Michael West. And there's a second event next month on successful teams. And I think the invitation is there for board members. I thoroughly enjoyed the leadership, compassionate leadership events that was held a month or so ago. And that's all I wanted to say, Andy. Happy to take questions. Thank you.
Yeah, thank you, Ife. It may be appropriate now, or it might crop up later, but just looking at the waiting times that you mentioned, and when we look at the differences between different parts, you know, for ADAPT, 16 weeks in Greenwich East, 1.4 for Bexley. We look at differences even within Bromley, or Bromley West and Bromley East. Do you think now we're moving to new directorates, or move to new directorates, that we'll be able to bring those things together? Because it does seem rather odd to have, as I say, within Bromley, you know, 2 neighbouring teams with such vastly different waiting times. You know, a lay person might ask, well, why don't you just share the workload rather than have such a vast? And of course, at number 4, the waiting times for ASD at 256 weeks is just extraordinary, isn't it?
Absolutely. So the answer to your first question is definitely yes. As you recall, this was one of the reasons why we pushed for the service line arrangement, because there was just far too much variation. And originally, we thought it was just variation across boroughs, but it's very surprising to now be reading about variations within the same borough and similar teams. And so this would be one of those things that I certainly would be expecting, and I think that my exec colleagues will agree that we get on top of. The ASD weight is of concern, and I think that if Lorraine, I'm not sure if Lorraine is with us, Lorraine is actively working with the rest of the ICS to find a solution to this. And again, waiting times is a real area of concern, and so we are going to focus on this, and we'll bring things back to the board through my report. Thank you.
Thank you. Stephen Lewis, please.
Yeah, thanks, Andy. Thanks, Ife. Yeah, just building on the ASD situation, and I know it's a long-term problem that we've had. The degree of comfort in Ian's report, he refers to the positions being filled, so that's good. That will have some impact. But as you say, it's let's face it, it is an embarrassment when you talk of, it's almost not a service at all, is it, when you talk of a waiting list like that? Just to manage our expectations at the board level, how soon do you think that comes down to a reasonable figure?
So I wish I could say with certainty. Fact is, I don't know just yet, but as you see, what I've been advised is that there are considerations being given to outsourcing. The trouble, of course, with outsourcing is that you bring down the waiting list and then it builds up again, because it's assessments only. So if it's okay with the board, can I go back and see if we can get a proper review of this, unless, of course, if Ian is able to answer that. But I don't feel able right now. I don't think the exec have the answer to that question. Ian, do you want to come in?
Yeah, I mean, I agree with you. I think that there are a number of actions that we're taking that we hope will have a positive effect. I think probably what we should aim to do, Steve, is to do what we've done with some of our CYP ASD weights and try and give you a trajectory. So for CYP, we've got a trajectory that takes us, sees us in about 12 months, or if not before, getting to a kind of reasonable place. And I think if we can do that for the adults, then that would give you a degree of reassurance about where we're going, that we are heading in the right direction. So I'll take that back and work with Lorraine.
Thank you, Ian.
Yeah, thanks very much. Are there any other questions for Iffy on his report? I was just picking up that point that Stephen made. I know without Lorraine it's a bit difficult, but when you look at that, you do think, is this a service that we can deliver when you look at, was that 256 weeks wait? And are there any other alternatives? And even if we do outsource, I do take the point about there is something about making an impact on that. I was just thinking that this might be something, again, an action we pick up from here for a more comprehensive report on weights in January, perhaps, so that we can have a really good look at this is a major issue, isn't it, for us to look at. Suzanne, please.
Sorry, it's a complete change of subject, Chair, but I didn't want us to move past Iffy's report without acknowledging the success of 2 of our nurses being identified in the Rising Star programme, and hopefully we could send them our congratulations as a board and acknowledgement of their achievements. Let's hope they stay at Oxleas and continue a successful career with us.
Yes, absolutely, and I totally do. So thank you for raising that, Suzanne. Without a doubt, let's make sure that our congratulations are sent through to those 2 rising stars, please. Thank you. If there's nothing else for Iffy, we'll move on to you, Ian, please. Thank you.
Thanks very much, Andy. So just as there is a new style CEO report, there is also a new style operational report. So we've taken the performance exceptions and routed them through the PQAC report, which will be discussed later on the agenda. And we've revised this report in line with suggestions from the board. So what you have in here is a narrative which sets out for each of the directorates achievements and challenges and developments that are kind of relevant to each service line. And just to reiterate something that Iffy has already mentioned, we have successfully moved our borough-based services over to service lines, and that went live on the 1st of October. And just over a month in, things have gone well. And I think it's down to an awful lot of hard work on the part of the service and clinical directors and their immediate team. So I just wanted to thank them for that. I think the report is fairly self-explanatory. I'm very happy to take any questions that there might be. I did want to highlight, because if you did mention it under COVID in his report, the schools vaccination programme that we've rolled out in Greenwich. I think this has, it's been not without its challenges, but I think it's now working extremely well. We actually hosted a visit from NHSE yesterday, and I think they were very impressed by the way that it's been implemented, and particularly interested in our partnership work with Charlton Athletic Community Trust. So although the uptake amongst Greenwich schools is variable, it's on the whole been successful. But very happy to take any questions on any of the other items in there.
Oh, yeah, thank you, Ian. I'm just wondering, what are the things that are on your mind at the moment?
Okay, I think we've probably covered a lot of them in terms of the BAF and what Effie has mentioned. I think weights, no doubt, are the common factor across most of our directorates. In terms of your ask, Andy, around greater visibility around what that means for us as an organisation, as part of the Zero Delays work, we are doing some work at the moment just to define that as-is position across all teams. I think there is, at directorate level, a lot of visibility, appropriate visibility of the weights, but what we want to do is to try and aggregate that up to a board level, and it very much links in with the work that Alison and I have talked about at PQAC, which is about refreshing our IBR so that significant weights are really in there. So I think that's one significant issue. I think there are some specific concerns that we're still working through at HMP Wandsworth, which I highlighted back in July at the board. And again, the action to address that is being taken through PQAC. And I think there are just the other things for me are around how our kind of large volume community services, things like district nursing, community mental health teams, how the developments at place, and particularly with primary care, are going to work to their advantage, because I think there's real opportunity here, given that demand is going to continue to go up, and although we can do some things to address capacity, some of this is outside of our hands. So there's a real onus, I think, on us getting that system working at place level, working extremely well, particularly between us and primary care, but also with the third sector as well. So some challenges, but also some, I think, some reasons to be optimistic in terms of opportunities that lie ahead.
Yeah, thanks, Ian. That's very helpful. Thank you. Jo, please.
Yeah, thanks, Andy. Just 2 points, and my first actually kind of dovetails into what Ian just said. So it's in relation to the development of the adult mental health hubs with Mind. Very interested to hear about that, and I would appreciate at some future away day just looking at sort of mental health pathways in each borough and understanding how it should work. But that seems a really good development. And the other one, and this may not surprise people, on page 58, we talk about the work we're doing looking at ED presentations and for the patients who are known to us, working whether we could have done something, I guess, in our normal pathways, which would have averted an ED presentation. I'm sure we are, but I really am also interested in those patients who present to ED in crisis and we know nothing about them. And because I do think there's potential issues over inequalities of access to services and such like. So I would really like at some point to also see the sort of the thematic analysis coming out of that side of the equation, as well, because I think, you know, that is a good area to focus on when we're thinking about inequalities, to actually say, are there areas of our boroughs or other areas of our populations who we are just not getting to, and they are not getting to us early enough. Thank you.
I think that's very helpful, Jo. Ashley, I don't want to just surprise you with a question, but yeah, you flagged. Over to you.
Yeah. Thank you, Joanne. And I'm Ashley Clifford. I'm the Service Director for the Acute and Crisis Line, and I loved your question, because often we provide assurance around things that we hope people want to hear, which is about really and truly understanding, you know, why are known patients turning up at ED. But just yesterday I had this very conversation with LGT colleagues, and what I was trying to describe with them, and which they agreed with me on, is that the pace of ED is such that actually all our staff rarely have time to stand back and understand the profile of people presenting. So I could have added a sentence there to say, we want to look at our liaison teams. SLP are about to start a project in December, but we want to reset our liaison teams and really and truly understand the profile of people coming through. And of course, as well as the known people, the unknown people. So what I want to understand is where, alternatively, should they have heard about crisis services and our crisis line and sought help. So what we're trying to achieve with resetting the liaison teams is to build in time and resource and some analysis time for us to understand the whole of the cohort and to reload resources as appropriate. And that may not always be in ED. That could be that we wrap around services around our police colleagues, make sure we're continuing to bolster our crisis line, but also to work across with Lorraine and Better Out of Hospital Care to make sure that we're promoting those services in the community, so that those folk that you mentioned, Joanne, that I suspect are there as well, and those new folk with newly emerging mental health needs following the pandemic, that we're properly promoting our services when we're ready to do so.
That's very helpful. Thanks very much for that. I suppose just back to you for a moment, Ian. I was thinking about as we're developing our new style of reporting, but back to my question was like, what's on your mind? Whether or not in that cover sheet you just highlight the significant issues that are of major concern to you. I know that might be repeating the bath, but it would be helpful just to know from your perspective. And just one other little question. I noticed we're recruiting some associate clinical directors. Can you tell me what they are and what they do?
Sure. So Abby may want to come in on this. So as we were moving to service lines and just thinking about our leadership capacity within the senior management teams, I think there was a question about how we might strengthen kind of clinical leadership. So I think some of the things that Aisling has described kind of really fit into that space. So from my point of view, often things around, for instance, bed management are seen as very kind of operational and about trying and seeing it in terms of demand and capacity, but clearly there's a kind of quality and clinical component to that, and it's really important to strengthen the voice around that. So I think we did talk about whether we should review clinical directors and the amount of time and capacity that they have to undertake this work. I think if I'm honest, clinical directors would tell you that they also enjoy the clinical work that they do, and they aren't all necessarily wanting to increase the time they spend on the CD duties. So I think this is an alternative way of getting the same conclusion. Of course, from a kind of retention and kind of recruitment point of view, it also helps us to look at developing new people. And I think it very much fits in with what Rachel was saying before around, you know, kind of developing kind of potential within the organisation. So we haven't yet recruited to these posts, and the exact number will probably vary from directorate to directorate. I think, Aisling, you're probably kind of furthest ahead in kind of thinking about the numbers. Although having said that, within Lawrence's directorate, and I know Lawrence is here, these are roles that you've had for some time, so there is a precedent there. But Abby, sorry, do you want us to add any more on that?
Thanks very much, Ian. You have covered most of the aspect, but it's also about the change in climate. So we've been talking about our systems and our play space and how we develop relationships across the ICS with primary care and with our place-based colleagues. So part of that is also enhancing our clinical voice and working on relationships, which is what some of the things that these roles will be doing in addition to what Ian has described.
Yeah, thanks very much. It's obviously entirely a matter for the exec. I'm always interested in new posts and cost, obviously, and where we're spending our money. Yeah, it'd be interesting to have an update on that in due course, if we could. Yeah, anything else at all for Ian? If not, shall we have a short break and come back at midday if we can? 9 minutes enough for everybody for a cup of tea? Right, okay, thank you. We'll make a start in about 3 seconds. So welcome back, everyone. We move on now to item 7. And Rachel, is that you?
Yes, thanks, Andy. So I'm going to talk about our third big priority under the strategy, which is about making Oxleas a great place to work. And this is part of a wider people strategy that will be coming to the next People Committee, which also includes things like workforce planning and recruitment and getting the basics right. But what this paper aims to do is to try to bring together in one place our priorities around staff experience. Many things that you're already familiar with, but there are some new additions in there too. We did cover some of this in the BAF discussion, so I'll do my very best not to duplicate what you've already heard. So the highlights of what's in the paper is that there is a really big focus on well-being, and it's important that we get that right, both because of the pressures of the last couple of years, but also when we think back to the conversations that we had as part of what our next step. Staff well-being was the thing that came through really clearly from all groups as being something we should focus on. So we've got wellbeing champions, we've got brilliant offers, we've got mental health networks, which are doing really well to kind of challenge stigma within our organisation, and a lot is happening in that space. Secondly, we want to make sure we've got a range of options for resolving concerns. So we've got our guardians, they are working well. We've got peer facilitation. We've got our staff partnership team who go out there and talk to teams directly to try and understand how things are going. We also want people to feel that they're really being valued and invested in and developed. And we've got a suite of new offers. Ify's already talked about our Ox Lead programme, and that's about trying to really upskill and invest in our frontline managers who have such difficult roles. We know that if we get it right for our band 6s and band 7s, we get it right for a number of people across the organisation, because they will lead and manage their teams as well as they possibly can. And there's been real interest and excitement in that programme. But there's also training on things like confidence on race or how to tackle disabilities, things that will make a difference to our frontline staff. We're doing a lot on engagement. We want people to shape what we do, and Abby and Lorraine and others have been really thoughtful about how we bring staff as well as service users to really help design what it is we do and to get some engagement, some strong engagement around our strategy work. We've also got surveys which we are determined to act on and listen to and make sure they inform what we do. Building a Fairer Oxleas is very driven by our staff. We've got staff assemblies, and you've also heard about our shadow executive, which has been a really brilliant way of bringing fresh thinking into what we do as a trust. And finally, the one I wanted to raise was about violence and abuse, and there's a lot happening in that space, as I've already discussed. And it's an area that we know that we've got to get right, because we cannot have the position that people come into work expecting to be the recipient of the sorts of abuse and violence that we sometimes experience in our organisation. So that's a really big and growing priority for us as a trust. In terms of measuring whether or not we're getting this right, we're looking closely at our leaver data and where people are leaving. We look closely at our staff survey results, as do we at our res and des results. And as Nina mentioned, we've been looking at People Committee at a really detailed leavers report that gives us some granularity as to why people leave our organisation. The biggest challenge for me, probably the thing I worry about the most, is that we do a huge amount in this space, but it worries me that it doesn't reach the people who need it to reach. So people who are working in really challenged environments where their day job is so demanding, I worry that things around well-being, things around equality and inclusion just don't touch the surface in terms of people really being aware of the difference that they make. So we're thinking about how we can do more to bring that to those environments rather than expecting them to engage with things on the Ox or by email or on Teams, and to think of ways that we can make it real for people in person. So we'll continue to have an overview on this at Executive Committee and People Committee, and we're also using the operational reviews to hear more about what's going on locally to make Oxleas a great place to work, because there are some fantastic local initiatives that really make a difference that we want to celebrate. That's what I was going to say. Andy, thanks.
Thank you, Rachel. A huge amount of work's gone on here. Thank you so much for everything you're doing on leading on this front. Suzanne, please.
Thank you, Rachel, for the report, and I found it's really interesting to read. One of the things I just wanted to ask you, and it's a bit basic, but the last board visit that I did, and in fact the one prior to that as well, the things that people were raising as their basic dissatisfactions as staff is what I would describe as pay and rations concerns, and not the sense that they weren't being paid enough, but they weren't clear about what their pay slips meant, that they didn't understand various different sort of agency or pay rates and so on. And I'm always struck that when health staff are talking on Twitter about their well-being, the stuff that really gets them is not having access to nutritious food on a break or at night, or not being easily able to access a decent cup of tea whilst they're on the ward. You know, those really, really basic things. So I was just wondering whether you could say something briefly to us in light of this. How confident are we that we've got those practical basics right, such that all of the additional work we're doing is on top of some of these really daily frustrations for staff working in the NHS?
Thanks, Suzanne. So I can you mentioned two elements of the basics there, but one in terms of pay and one in terms of food. I can probably speak much more about the pay element, but might want to bring Abby in about the food, because I know that with doctors there's been particular questions about whether or not we're getting the right things available for people. Pay is tricky, and there's a steady stream of pay issues that we try and resolve as an organisation, and ASRA might want to come in on this too. So We are trying to, so in response to some of the questions that have been raised in those visits, we're trying to have to make it much clearer for staff about what the rates are, what they can expect if they do a bank shift, for example. I know that hasn't been as clear as it might be, and that's an issue that Lawrence has raised, and so you'll also see that in one of the board visits. We're also trying to help people to actually understand their pay slips, because these things aren't straightforward at all. So our providers are going to be coming to some of the areas where people have been really struggling to help them really, decode their payslip, I think, because I can't always work mine out. So, I can understand that people who are doing a lot of bank shifts might really struggle with it. So I think there is more that we can be doing. That is a big part of our people strategy. So the back to basics bit of it is there. And you're right, that has a direct impact on staff experience. As does recruitment, really, because if people have got vacancies as well. So in a way, the whole people strategy is going to try and tackle these issues. I don't feel, to be honest, Suzanne, as close to understanding whether people feel they have access to the right food. But I do wonder if anybody else would want to come in on that point. Abby, is that something you'd want to speak to?
I can speak to it from the medical workforce point of view, because this is something that we are monitored on for our trainees. So they need to have access to rest facilities, and we are monitored on that. So they do have access to rest facilities. In addition to that, the British Medical Association has allocated funds to each trust. So they have funds which they themselves have access to. So anything that would make it easier for them in terms of their rest. But I want to say that for other professional staff, I know staff assemblies are working on providing rest and recreative places for people where they can go and have some downtime and have access to food. So it is something that is being looked into for all professional groups, and I think it will only grow and grow. And I think the good thing about it this time is that the control has been given to those that actually use those services, so that they can plan and determine what their rest facilities and their access to food will look like.
Yeah, thanks, Abby. I mean, that's a really good question, isn't it, from Suzanne there, I think. Who's waiting? Stephen Gilworth, please.
Yeah, thanks, Andy. And thanks, Rachel, and very useful to remind us all about the excellent work on violence and aggression. 40% reductions is terrific. And also the reminder about the very difficult environments in which our staff work. I just wanted to remind us all, of course, about the to what extent perhaps the charitable fund can play a part in helping you deliver a lot of those improvements. There's quite a chunk of money sitting there, and 61% of it is unrestricted. And it's not just about training. It might speak to the point that Suzanne just raised in some way about provision of better food, but I mean, that's entirely up to you. But that fund has actually increased in the last year due to lack of use during COVID. But I think we should be using it, and the work that you're doing, I think, would fit in with it very well. It would be all about our staff, which is what the original donors pretty much intended.
Thanks, Steve. That's a really good point. And we do give £10,000 worth of charitable funds to each of our directorate staff assemblies, precisely so that they can focus on things that make the biggest difference locally. And as Abby says, sometimes that is about kind of rest areas, because we know that's so important for decompression. But I do think we need to encourage people to be bold in their ideas and to see the charitable funds as being something that we can draw on. It's a helpful reminder, Steve. Thank you.
Yeah, thanks, Rachel. Ian, please.
Yeah, it's just to come in on the back of that and what Abby was saying. I think it's a really helpful reminder about the fact that we have the staff assemblies, because I think personally I've always felt slightly uncomfortable that because of the kind of context of medical training, the kind of needs of that particular workforce have been quite rightly highlighted, but of course it shouldn't be to kind of denigrate the needs of other professional groups. And I do think both the staff assemblies and, as Steve says, the charitable funds puts the onus back on us to kind of level the playing field, really. So, yeah.
Thanks, Ian. Sue Sauter, do you have your hand up? I think I've got that wrong. Steve James?
Thanks. I thought this is a great item. I thought it put all in one place, all the things that we're doing to make Oxleas a better place to work. And it was really good to see how the things they were all of a piece, so that you could see that we were doing something about that over there and something over here, and it all interconnected. So I thought it was great. So thank you for that. I particularly like the first line management courses, because I think if we crack that, we've cracked everything else, to be perfectly honest. Because the people who actually have face-to-face contact with patients work to those people, and if they're happy, basically we're happy. Every issue we have is often rooted back to first line management, good or bad. And also I think there's quite a lot of evidence now that this approach is getting through to people, because I went to the Black History session a few weeks back, and it was very clear that people understood the initiatives that were being had by the trust, and that they had clearly got the message that we were taking it seriously, and it had an effect on their work. So if we put to one side singing happy birthday, which we've already been through, there was a lot of evidence that those initiatives are actually getting through to the people that we need them to. So I just think it's great.
Well, thank you. Thanks, Steve. Yemisi, please.
Thanks, Andy. I just wanted to make a comment leading on from Suzanne's comments about providing the basics for our staff. And it's just a plea really for us to remember those of our staff who work in non-traditional areas, those who work in the community, those who work in service users' homes, maybe in care homes, that we also need to ensure that they also have the basics as well. So yes, I appreciate that money is given to each directorate, but I think from a central corporate perspective, we need to support them to ensure that all staff benefit from this, and it's not just in the traditional areas. Thanks.
Yeah, thanks, Yemisi. I'm just wondering, how do we capture this? I mean, echoing Steve's point, a tremendous amount of work, but that particular point, going back to Suzanne's question about food, about basic facilities, how do we capture that in some meaningful way? I was almost wondering if if one did it ward by ward, even if you only did a little bit at a time. I accept what Yemisi says about people not on wards, but we're all saying the right thing. It's just sort of, what do we actually do? Iffy, please.
So I was going to say a couple of things, if I may. So the first is, one of the things we've tried to do, and this speaks to Ian's point with the junior doctors, is that we have deliberately avoided creating a separate rest area for them. So we try and ensure it's the same rest area for all staff, perhaps at Oxleas House, Green Parks House, etc. And so the investment that we've received really does benefit other staff too. That's the first thing. The second thing I wonder is whether we ought to, particularly picking on Yemisi's last point, whether we ought to look across our sites, because I'm not sure, like Yemisi, that we're paying enough attention to our community staff, partly because we think they can pop along to nearest Sainsbury's or Starbucks or any of the other shops that are around them. And maybe we should just think about a dozen or 2 dozen community sites and inpatient sites and just check, because this is what what's required of us when we have to feedback about doctors. So there's no harm as an organization in us doing this. It's going to be a lot of work, but we can be exact and think about how we do this outside, and maybe consider at a later point bringing something through this particular strategy to the board.
Yeah, thanks, Tiffany. Rachel?
Yeah, just very briefly, I think it would be great for us to find out what the real need is for people and to meet that need. So, for example, I know as part of our work with the Women's Network, there's been a lot about period poverty and whether there's more that we could be doing as a trust to tackle that issue. There are things that we could be doing, I think, to make sure that particularly our most junior paid staff, that we're really thoughtful about the pressures on them and their money. So I think this is a good thing for us to be exploring. I am aware, for example, when we were in the height of COVID, we did think about whether or not we could be bringing food to particular areas. And it's a real challenge for us not to only be focusing on our inpatient kind of facilities and to make sure that that's all accessible to our community staff in the same way. So, but I don't think that should stop us trying to find the right solution. So I think it's been a really useful discussion, and we'll take it away and have a further think.
Yeah, thanks very much, Rachel. I just think that was some really good points there. It was be a great one for You Said We Did, wouldn't it, on this front? So, but thank you again for all the work you've done on there. Is that you next, Neil?
It is. Thank you very much, Andy. So I'll be giving us an update on building block 2, which is about involvement and co-production. Just as a brief sort of outline, nothing about us without us is now an expectation across the NHS and across, I think, all public services. In the paper, I've given some specific definition about what we mean by that, because actually there are different levels of involvement and co-production, and we want to be aiming for the top level because that's where the real big gains are. We want to make this co-production maximally at each level of the organisation, including the board. And actually, in a minute, we'll be playing a short film just from people who've used our services and are now contributing to their design, because I think that could be a really useful way of us getting sight of some of the foundational evidence that some of the decisions we're making in terms of our redesign services, what that's based on. In 2018, we were told that we had some very good pockets of co-production by the CQC, but that they weren't particularly joined up. I think that situation is improving. I think we are increasing the numbers of co-productive activity we're doing. But after we've looked at the film, I'd like to talk about how we begin to address the join-up between these different projects. So in a second, Steve will be showing us a film. But just to introduce this, a very exciting area of co-production that we're looking at the moment is in our mental health crisis response. Mental health crisis response is really dependent on the very first minutes of how the contact is made. What we do know about that is how those minutes feel will affect the rest of the treatment thereon. So if that works well, that can really help matters. If that goes badly, that can either cause disengagement or increase risk. So what we need is information about how we make those very first moments work. And of course, lived experience is the absolute gem for this. So being able to ask people who've used our services what worked, what didn't work, is going to be a really, really useful guide. So the film we're about to show you is based in our crisis line service, which we're redesigning, and Aisling is leading on this. This, I think, when we look at the process, is a very high level of co-production. You've got people involved from the beginning. The meetings are adjusted so that they can take part. And actually, eventually, the service itself will be involving people with lived experience in delivering this. But I wonder if we could just now look at the film so that we can hear from people who use our services. And then I'll describe how we use this information. Thanks, Steve.
I believe the most important element in helping people with crisis is compassion.
Answer with an empathetic tone, acknowledge that person's name, reassure them that they're being listened to, offer a listening ear, really.
You just don't feel heard or seen. You just feel like another number. It's the thing that it can do to someone's mental well-being when they believe that they're not good enough. And then something happens to reinforce that, which could be a professional not giving them the time or the professional seeming busy. If you are sitting with someone or speaking to someone who is in crisis and they feel that you're too busy to be there, that's only going to hurt them even more.
Because if you make people feel like, you know, there's a rush in giving attention to them, they will know that, you know, your attention is divided. So, you know, full attention is really important.
they were just steering me away from any risk. And I would say they were trying to keep me in a safer place in my head until they could act on information that they could use to keep me safe.
You have different kinds of people, so you have to kind of almost tailor your approach to them. And it also, it doesn't even just depend on the type of person, it depends on where they're at that moment. If there was some kind of way that we could formulate almost like a triage to see where this person is and what kind of response they need, then that could help.
It's really important for the service users to not just have, questions fired at them, but to also have the opportunity to share their views about the kind of questions that they want to be asked as well.
In terms of having people with lived experience, I think it's important to have people with lived experience involved in all aspects of healthcare, whether it's a new project, evaluation of services, or indeed in our workforce. We do need to have people with lived experience who can influence everything that we do. In terms of our crisis line, it's important to note that people with lived experience are the ones who have been dialing our crisis line over the years, struggling to find the number, or struggling to navigate our website to find the number, or indeed then trying to articulate themselves at that very moment where they're potentially at their most vulnerable, or in the middle of the night where they're desperately worried about a loved one. So by including people with lived experience, not only as contributors to the project and the design, but to make sure that the bulk of our members of our steering group are people with lived experience, what we can make sure is that their experience directly influences everything that we do. In my experience, it adds a greater level of integrity and validity to the discussions. People who have called our crisis line in the past, or indeed people who've wondered how to get help in a crisis, there's no arguing or there's no diluting that experience. So we can immediately make sure that that suggestion is included in, for example, a comms plan, the method by which people contact us, whether it's by text, whether it's by chat line or by telephone. We can immediately consider a dilemma based on the experience that that person describes in a steering group or in a project. In terms of my experience with having people with lived experience in a steering group, what I have noticed is that it creates a transparency to the group. We are immediately forced not to use NHS speak, not to use language that is exclusive, to really get to the point and look people in the eye for what it is we're trying to do. So what I try to do when we're working with people with lived experience is to try to ask them, what has their experience been? And to try to say to the leaders, including myself, can you look everybody in the eye now and properly describe what it is we're trying to fix? And can you come back next week or next month or in 2 months' time and look that person in the eye and say you fixed it? Because if it, for any moment you cannot look our colleagues in the eye and members of the steering group in the eye and say that, then there's something we need to do better.
Thank you, Steve, showing the film. Just before I take questions, either on the film or the types of projects that we're looking at, there is one point that I just want to get to, that we could still be criticised for saying this is a very good example of co-production, but it may yet still be a pocket. It may be isolated. So the paper is outlining how we're going to address the spread of this practice, and that is through developing an infrastructure. So the key elements of the infrastructure is to give the subject area itself some leadership, co-production and involvement. So rather than that being a part of everyone else's job, we actually have a centre of gravity for it in the trust. And that will include having an advisory committee, a group where we bring all of this together. We're going to employ some new roles, bringing back our carers lead role, which we, I think, have sorely missed over the last few years, but also some people participation lead roles. These are the roles that sort of make it happen. They prepare all the nuts and bolts to actually prepare people to come together, to come to these meetings. And lastly, I've outlined some of the measures that we'll be looking at, because as an infrastructure, we're there to support other people to have outcomes. But I think what we could do with as an organisation is some sense of where the co-production is happening, the quantity of it, but also the quality, using those stepped approaches. So I'd like to leave it there, and I'm very happy to take questions either on the film this way of bringing lived experience to the board or the infrastructure itself.
Any questions, colleagues, at all? Steve, James, please.
Thanks. I've just got a couple of comments, really. I really welcome this. I think, Neil, you can be a bit more. We can have slightly more expensive outcomes, because I think one of the things we need to do, we need to be a bit more confident about this. So I think that it will have really seriously beneficial outcomes to people's health. I think involving people in designing services, either at an individual level or a team or organisational one, will benefit them directly. So, you know, in the outcomes on an individual thing, if you were trying to explain to the person at the bus stop that the support network engagement and care planning audit scores were improving, it wouldn't hit the mark. Whereas actually people are going to get better because of this. There's loads and loads of evidence that involving people with lived experience in designing either their own or teams' services for them will have positive results to their mental health. So I think we should be a bit more optimistic about this and say, actually, what this is about is to improve the mental health of the people that we support by involving them and people with lived experience. I think we could be more confident about it. I really like the point about trying to broaden it out. So I think some sort of scoring system that says, you know, to what extent has this service involved people who receive the service or their families or similar ones is really useful, because it will give us a picture across the trust. And my last point, which is, you know, just a slight, not negative, but a slight challenge, is I always worry about initiatives that part of the answer is to create quite a lot of new posts. So I wondered within the trust whether or not, if we're going to create those posts, some of those I know cancel themselves out, can we save money somewhere else? Because I think there is a temptation to always think that the answer to something is another person or two, and at some point or other we will need to say, well, we haven't got the resources, so what should we not do in order to, this is really important stuff. So is there something that's less of a priority that could fund this, because, you know, money is tight? But overall, I really welcome the approach.
A very helpful point. So your point, I think, about health benefits, I think you probably would tie that to people defining what they think benefits would be for themselves as individuals as well. So the whole thing about care planning is in there. And I think you're right that as we go on, co-production will become something we do instead of other things, not just as well. So that's certainly something we were looking at as we were steering the business case through. Very helpful.
Steve's point about more staff?
More staff. What's the point about, so these additional staff are there to, as I say, pump prime the infrastructure to get the join up. I'll just make sure I want to understand, Stephen.
Sorry, yeah, Neil, I wasn't necessarily arguing against those posts because I can see what their role is, but I suppose the challenge is to the executive to say, if they're really, really important, given our financial situation, have we gone through some sort of process that says, well, we spend some money over there which is not as important as this? Because in the end, everything becomes important, and we won't have the money to constantly have the thing that says, you know, whatever the question is, the answer is more staff.
That's a great point. And I think to answer it, what we would say is that ultimately we want co-production to become part of existing staff role. So we'll be looking at job plans to make sure that people have time to get involved with this, because that's where you get the efficiencies and the effectiveness gains by kind of changing the way that people approach care planning, doing things at a team or at a sort of more macro level. So job planning will be part of that. And I think it isn't always about additional posts, as you say, it's about what it becomes a part of everyone's role.
Yeah, I suppose I get that. But There are new posts, aren't there? I suppose that's the.
There are new posts, yeah, and that's to pump prime the infrastructure, because the new posts are about preparing service users to be able to come to our meetings. That's a big area that we need. Plus, when services say we want someone from perinatal and we need them with this experience, we need to have a sort of a bank of people that we can go to and prepare. So it's a sort of supply and demand issue. That's more about just bringing people together, but the actual co-production should be frontline staff.
Yeah, thank you, sir. I mean, I'll come to Suzanne in a moment. I was just wondering, Vazra, are you going to go up to?
Yes, I was going to come in exactly on the point that Steve had said. I understand earlier on I was breaking up, so if that does happen, I'll turn off video if you just let me know. We had that exact discussion, Steve, and we had really quite a protracted discussion at executives when we were talking about bringing in additional posts. And in the end, the funding mechanism is a top slice to the clinical directorates that will benefit from this co-production. So I think what we've done is people have actually put their hands in their pockets in regards to each one of the directorates to show that they are really value this particular piece of work. And what we've said is going forwards, we need to be able to capture what exactly is going to be the financial saving. Because the issue is, exactly as you were saying, if we do this correctly, and if we do get the co-production correctly done, we should begin to see that we're having shorter interventions or less protracted interventions, and perhaps not having people that are sitting on people's caseloads for year after year, because we're actually better focusing the help that we're going to be giving them. So that was quite an extended conversation. We talked about baselining, and we talked about really understanding what the financial benefits were coming out of it. But just to kind of reassure you, people recognise the fact that it wasn't just additional posts, because what they're recognising is we think that this is an investment that will actually drive lower costs within the directorates ultimately, and absolutely will bring the quality improvement that we're hoping to in terms of how focused our services are. I hope that helped to answer that in a bit more clarity.
That's very helpful. That's right. That does show the confidence of the exec that this is going to reveal real benefits. Thank you. Suzanne, please.
Got one comment and one question. The comment is that I was absolutely delighted to see this come forward, and I think that as a trust we have been a bit underpowered and lacking in expertise across the piece in relation to co-production. And my sense of joining the trust as a NED was that the CQC's comments on their previous visit were spot on, that there was some real expertise in some areas, but it hadn't spread. And I think that what has been striking to me is trying to raise the level of discussion about co-production, particularly in the quality improvement work that we do, and not, having had kind of fairly limited and rather slow traction in that space. And I think that this could make a really significant difference. And what I would be hoping for is that this is about building capability, and it's a capability that expands well beyond the small team that Neil's putting together, but it does need that pump priming. I did have a question. I think when I read Neil's paper, the thing that really interested me was the comment that the primary area of co-production has got to be in care planning, because we've had so many discussions about care planning as a board and at PQAC, and I was quite struck that this is sort of Neil's starting point. So I was just wondering, Neil, if you could say a little bit about where this will kind of sit in your plan for taking the work forward. Is care planning going to be something that will be a first priority? Will you be starting out perhaps at the team level with service lines and then moving into care planning? How will it be staged?
Thanks. That's a really interesting one to tackle, because you might think the individual level at care planning might be the easiest because it has less people involved. I think that's really not the case. I think the first level will be team level, because I think there needs to be interpersonal learning amongst our staff, because I think we have varying levels of confidence in how to do this. This was not in our basic training. For most of us, this is a new element. And actually, I think if we can make teams learning, very much in line with building block 3 about safety and learning culture, what I think we need to then see is that people are picking up from peers within teams, ways of doing co-production, ways of listening, ways of applying that listening into planning that then is applied to the individual level, because most of the care planning happens behind closed doors. It's very hard for us to kind of keep a track on it. And I think often if you're not confident as a member of staff, then you feel you're on your own with it. So I think there's going to be a lot of group learning first. And actually, I think we should not underestimate how challenging the individual care planning approach is. Not care planning approach in the formal sense, but just building a co-production. What are your goals? What are our goals as an organization? How do we match that? I think that takes a lot of confidence. So that's where we're going to be focusing mostly on the teams to start with, and then getting the teams to look at that more granular level after that.
Thank you, Neil. Stephen Dilworth, please.
Yeah, thanks, Andy, and thanks, Neil. You know, it's a program with huge potential, I think, and I'm really delighted what you set out for us. And also, thanks to Aisling for the guidance she gave us, which I thought was very useful in terms of getting the best out of our service users. A couple of things strike me. First of all, as mentioned earlier, charitable funds I think would be could be very suitable here. Building on Steve's point about the outcomes, I thought the same, that needs a little bit more work. Unusually, I think, actually, aside from metrics, I think oral feedback on the films that you've used would be quite useful as outcomes here. And I do realise it won't be suitable for all the end users or the service users, but I think that would be quite powerful and quite a good anecdotal, but nevertheless still relevant measurement of the outcomes on the programme. And in respect to the vacancies, and I understand how from Azra, how you've allocated the budget for that, but starting off from the small scale, I would think this is ideal for collaborative work, either through the SLP or the ICS. You know, that certainly worked for eating disorders, young onset of dementia, two projects that strike me that no one could manage to do really individually, but work quite well within a collaborative forum. So I guess the most important of all those points is probably the charitable funds, because it's going to be all about the money. But I'd be interested in any of your thoughts about working collaboratively with other organisations, if you see there's some potential for that.
They're great points. So a couple of things on the collaboration. So the infrastructure that we built is compatible within the SLP. So that and the ICS. So we've used the same infrastructure that our colleagues are using. So we've got some inbuilt compatibility there. I think the other area of partnership is that we are bringing together two areas which were not sort of so strongly linked before, which is volunteering, lived experience practitioner, and membership and partnership. So Joe Mant has been holding a great sort of resource in terms of our partner organisations. Actually bringing those together through the advisory group is the way that we hope to kind of join all that up a bit, so that we can actually not just kind of work with partners, but involve people and get a bit more traffic between kind of organizations. That's where we're hoping this sort of, as you say, working as kind of groups will happen. Because certainly for our service users, you know, the organizations are a little bit of an abstract differentiation. They're much more interested in what happens in their borough. And that has a number of organizations. So when you take it from their perspective, they would like to move between third sector, NHS, and different community groups. And I think we'll get a lot of clinical advantages from being able to link up in that way.
Thank you, Neil. Anything further for Neil? Well, then, if not, excuse me. We'll just go on to the serious incident report. Just before we do, there's a lot of detail in this report, and I think we need to have just reflect about how much detail goes into the public domain. So perhaps people who've read it, I think we keep some of that background detail brief. We might have a think when we get to part 2 about what we put in these ones in part 1, I think, at least after all our public documents. I appreciate that Jane's not here, but I think Ian, you're presenting on this. Thank you.
Yeah, thanks very much, Andy. So, yeah, I'm presenting as co-chair of the panel. I completely take on board your points. What I was going to do was just to set out briefly the context of why this particular death in custody had been treated as a board level review. I'll touch briefly on some of the details of the case, but then go straight to the summary of the key findings and the recommendations, if that's okay. So just by a way of context and a reminder to colleagues on the board, this very sad death was one of a number of deaths that in custody which took place at HMP Wandsworth between the beginning of the year and June. And this was actually the 5th of those deaths, and within a short space of time there were 2 further deaths in the same month. I am pleased to say, and I realise this is a kind of low baseline, we have had no further deaths since then. But I think in acknowledgement that this was a high volume in a short space of time, it was suggested that this should be done as a board level review. Because the mental health services at HMP Wandsworth are subcontracted to South London and Maudsley, we did it as a joint review with myself and James Lowell, who's the coup over there, as joint chairs. And the 2 remaining, the 2 other subsequent deaths in custody are being reviewed separately, but any actions that, any recommendations which lead to actions from those reviews will be incorporated into one action plan for all 3 deaths. And I plan to bring this to the January board. But in terms of the specifics of this case, PM was a 34-year-old Polish national who was found suspended from a ligature point in his cell on the 8th of June this year. He was a sentenced prisoner and was awaiting extradition. And you've got a very kind of detailed timeline, but essentially PM arrived at HMP Wandsworth in October 2019. And as the timeline indicates, during the time that he was in prison at Wandsworth, he exhibited an extensive history of self-harm and a number of suicide attempts. And this is in the context of quite extensive use of self-produced alcohol. While he was at HMP Wandsworth, he moved quite often between a regular cell, and these cells are for 2 people, and the care separation unit, which is a facility that the prison has to isolate prisoners, and it's usually in the context of the risk that they pose in terms of violence to others, also damage to the environment. Because of his self-harming behaviour, he was referred on a number of occasions to mental health services, but because of a lack of a formally diagnosed mental illness, was not taken on for treatment. He did, however, have some engagement with CGL, who are a third sector organisation who provide substance misuse services at the prison, subcontracted by Oxleas. And the ACT framework, ACT stands for Assessment, Care in Custody and Teamwork, framework was used by the prison, as it is throughout all prisons, to manage the risk that PM posed to himself. So in summary, he was in Wandsworth for around 18 months, extensive history of self-harm, and a number of attempts to take his own life, and its intermittent contact with healthcare services, and the main framework for keeping him safe was ACT. But in terms of the summary of the key findings, so these are highlighted on page 92 of the bundle. As it says here, PM's impulsivity, and it was often in the context of alcohol consumption, presented a challenge to the prison regime and resulted in an extensive history of acts of self-harm and attempted suicide. I think the panel felt that the ability of the organisations to provide a comprehensive framework of support was compromised by broadly three factors. The lack of a developed universal primary care mental health offer, the way that the ACT process was operationalised, and the quality of communication and information sharing took place between different agencies. In terms of recommendations, the panel didn't identify a single root cause, although there were a number of contributory factors identified, and therefore we've made 4 recommendations. So the first is around the mental health care offer at the prison. There was already an action plan in place, which is being overseen by Lawrence and his counterpart Slam. And this action plan has a number of component parts, but one of the specific points was to develop the universal mental health care offer to prisoners in HMP Wandsworth, as specified by the contract. What's clear, and it was made clear through our the kind of panels, the panel process, was that there is a fairly well developed secondary care offer for people who've got a diagnosed mental illness, and that is a kind of an in-reach function as well as an inpatient function. But the broader kind of mental health needs of the prison population are not sufficiently catered for at the moment. So there are some specific points under this recommendation. We felt that there could be improved screening on arrival at the prison to holistically understand the needs of the service user. So that was really to get a much better sense of the person's background, and including mental health needs at the point that they enter the prison. As I said before, a defined primary care mental health offer as specified by the contract. I think there's something about having a much better articulated operational policy for mental health services in the prison. And then finally to deliver training to all healthcare staff. So that's both staff working in primary healthcare as well as mental health care around risk assessment. So that was recommendation number 1. Secondly, the second recommendation was around the ACT process itself. I mean, this is this framework is pivotal in keeping prisoners safe, and it is the responsibility of the prison to lead on. But we really want to see healthcare management at HMP Wandsworth working with the prison to deliver the revised Act 6 framework. So the framework itself has been revised recently. There needs to be a clear referral process to healthcare as part of that framework, and clear standards for staff from all agencies to adhere to. And this needs to embody a true multi-agency, multidisciplinary approach. And as a particular point, we felt more could be done to highlight the importance of including family and a sense of the person's family in that process, because it is a clear protective factor. And then the final two recommendations were around healthcare staff having a clear escalation procedure for raising issues through management with different stakeholders. I think this was an acknowledgement that prisons are a challenging environment to work in, and sometimes communication around issues that are getting in the way of effective multi-agency working weren't always escalated in the way that they should have been. And then the final point was just having a much tighter referral process, so that mental health needs are properly documented and key information highlighted in all cases. I think we saw examples of quite poor practice in terms of how referrals were undertaken. So, as I say, we will I will work with Lawrence and colleagues in SLAM to turn these recommendations into an action plan, and I will bring that back to the board in January. But happy to take questions on anything I've presented.
Thank you, Ian, and thank you for such a thorough report and presentation. Does this report go to the SLAM board as well?
Yes, it will do. So because of the kind of partnership arrangements and the contractual arrangements, I've been working with James to make sure that there is a parallel process followed with SLAM. But it is coming here to the Oxleas board ahead of an appearance at the SLAM board.
And obviously CQC have been to Wandsworth. Have they seen this report?
They haven't. The kind of the next stage of the process is, now that it's come here, we will share it with NHSE. I don't know if other exec colleagues can guide me in terms of any sharing with the CQC or not.
Yes. So once the board signs it off, then it goes to NHSE and then CQC.
Okay.
Thank you. Suzanne, please.
It's not a comment on the specific findings, but I was disappointed to see another SI report come to the board with the statement that you didn't find a single root cause, because that's not the point, to be looking for a single root cause. And, you know, I've raised this point, I think, every single time that an SI report has come to the board. So it may be that there's a fundamental disagreement between myself and those who are responsible for signing off the reports at an earlier stage about what a root cause means, and we need to have a discussion about that. But you know, so far I've sort of raised it, as I say, on almost every occasion that a report has come to the board, and we don't seem to be making any progress on this.
I just wondered, is there any guidance on this? Because we used to talk about root cause analysis, and I thought there'd been some change in that. Yemisi, please.
Thanks, Chair. Ian, you mentioned that there were 3 deaths or 3 SIs. Of the others, deaths had completed SI reports, and has there been any triangulation as to issues amongst all 3?
Yeah, so there were 2 subsequent deaths following PM. They are still in the process of being reviewed. One is being led by Chris Nakin and the other by Anna Gillespie, both from Forensics and Prisons Directorate. So they're about to complete. I mean, just in terms of kind of headlines, Yemisi, one of those the person appears to have taken his life in a similar way, as in it was a ligature incident within the person's cell. The final death was different in that it was an overdose. But until I've seen the final reports, which I will do in the next few weeks, it's difficult to draw any conclusions at this point. The previous 4 deaths that took place before this one since January were all ligature incidents.
Yeah, just going back to Suzanne's point, can we pick this up about this root cause issue? You know, if we can't answer it now, then let's pick it up, please, because she has raised this in the past.
So Andy,
yeah.
I will pick it up with Jane and Jane's team and make sure that we consider this for all future investigations. I know Suzanne has mentioned it, and certainly when she and I worked on SI, we spent a great deal of time talking about this, but it's probably the fact that this hasn't quite spread to everyone who is involved in these investigations.
Yeah, thank you. There's another hand. I can't quite see whose it is.
It's Joe.
Oh yeah, this Joe, please.
Hi. Yeah, just want to pick up on the findings, particularly the one around the word we can't say, around the ACCT process. And I think whilst these actions are particular to Wandsworth, I think that is something that is worth certainly reviewing across all our prison estate in terms of the way we interact with that. I mean, I think it was particularly poor at Wandsworth, but as Ian said, this is the main system employed in prisons to try and keep people safe. And I think we should do a real temperature check on how we are inputting into that process, because I suspect, if not everywhere, in lots of places there are improvements. And I think it's a real subject matter we should talk to governors about, and we should talk about when we're doing bids as well, because I think there are real opportunities to work around that. There are lots of challenges in doing so, not least because the prison service is quite short-staffed, and we've had COVID and such like. But I think a more collaborative approach to that would really reward the effort in prisons.
Is that Yemisi?
Thanks, Andy. It's a bit of a follow-up question from my original question, but Ian, are we expecting at the board for some sort of paper that considers all the deaths and triangulation amongst them and common themes to come back to the board or to go to our regulator, or it's just the case of doing individual SIs and then we're going to pass them on?
So NHSE have already undertaken a thematic review which took place last Friday. So that looked at all 7 deaths, and we participated in that review along with colleagues from SLAM. So I think we're waiting to see what that shows. I think from my point of view, and I think Lawrence is still with us, it would be helpful to look, once the final 2 reports have come in, to look at the triangulation, as you say, not just the last 3, but the previous before that. So I think some of what was coming up in terms of the previous reports has already been incorporated within the action plan to improve services at Wandsworth. So I don't think there's anything particularly new that's come out from the kind of final 3 deaths, but we will bring all of that together. And I think, just from my point of view, I think one of the challenges of doing reviews in prison is that there are kind of limitations to the review process, in that, for example, we didn't have access to any of the prison records. It's a context where there are a number of different agencies working, and so I think the process we followed is our best attempt to try and bring some of this together. But I think, as both you and Suzanne and Joanne have said, we one of the key conversations now that this report has been completed is to have a conversation with the governor himself, and to kind of think about, particularly in the context of ACT. And then the other key conversation is obviously what the findings suggest about the mental health care offer in the prison, which again is part of that existing action plan, but I think the findings from this report may sort of accelerate the pace of change that we need to kind of see.
Lawrence, did you want to come in?
Well, Ian actually brought up the point that I was going to make around the thematic review that was conducted last week, and we will get a report from that. The governor was also involved in that thematic review, so he's fully aware of the issues and concerns that we have as an organization, as well as our partners. There was a PFD from one of the coroners in terms of documentation in a single system, and CGL has a different system. So we're working with CGL to make sure that everyone is documented in system one. So we have all the documentation in one place rather than 2 or 3 different systems. So we are in process of getting them to agree that.
Thanks, Lawrence. Anything else on that? If not, again, thank you, Ian. These are very, very difficult things to do. And I appreciate the challenges of doing them as well. I'm very grateful for your leadership on this matter, and to you, Lawrence, as well, for trying to get to the bottom of all these matters. Let's move on if there's nothing else. Iffy, please.
Sorry, thanks, Chair. I was just going to make the point that for items 9 and 10, in Jane's absence, Abby is going to introduce them both.
I'm grateful, Iffy. On this next one, Abby, I suppose again it's focusing on the areas of concern. It's obviously quite an extensive report, but over to you.
Thank you very much, Andy. So this report is the biannual safe staffing report, and this covers the period from the 1st of January 2021 to 30th of June 2021. And what happens is that over 21 consecutive days, the staff are asked to use the mental health optimizing staffing tool to look at levels of acuity to ensure that there's adequate staff on the ward. And the review did show that there are sufficient staff on the ward, and in places where that doesn't happen, or instances where that doesn't happen, there is a contingency plan. The other thing that was looked at is ward acuity, and this was benchmarked against a national database, and it just showed that our TAN, which is our psychiatric intensive care unit, is a bit of an outlier, and the report shows the narrative around what's being done about that. The report does say the Greenwich Directorate, but I think it's now passed on to the Acute and Crisis Directorate, so Ashling's team will be looking at that. It did show a higher level of acuity in Holbrook, which is an older adult dementia intensive care unit, and that just speaks to the level of need that those patients have. The other thing that the report highlights is the combined care hours for patients on the ward, and this looks at both the nursing and the allied health professionals, and this showed that we're just above the median, which is a good place to be, because it shows that we're running productive wards. Because if the figures go either way, it can either mean that your wards are being run inefficiently, or there's an impact on staff if that indicator is low. So I have nothing else to say. The only other thing I have to say is that Meadowview and the Eltham community beds were not included in this review because they're being reviewed separately as part of an evaluation and review of the service and the intermediate care beds. The last thing that was reviewed is the incidents, and there were no level 4 or 5 incidents that had anything to do with safe staffing. So I will try and take any questions, or I will pass the questions on to Jane.
All right, Nina, please.
Thanks, Andy. Thanks, Abby. 2 questions, please. Which committee did this come to before coming to board, Abby? Do you know?
I don't know. I don't know whether it goes to the patient safety. I'm not sure which committee it goes to prior to coming to the board.
It used to come to workforce, and this one hasn't been to that committee. So I just wondered if we've had a change that I'm not aware of. I'm happy to take that offline, but okay. So we missed a trick in terms of this not actually coming to a board committee before coming here. It seems, is that right?
I can see Rachel nodding her head. So
yeah,
yes.
Okay. So can we pick that up offline, because I think there's a number of questions. We normally give this report quite a comprehensive go over in that committee, and I think there's a number of questions that I know colleagues have. So I won't seek to get in the way of that discussion, but I will just leave that there, please.
I'll take that back to Jane.
Yeah, thanks for that, Nina. That's a really good point. Steve James, please.
Thanks. I was struck about the acuity figures in the Tarn, which you mentioned, Abby, because either people who don't need to go are going in, or people are, the situation is getting better and they're staying there too long, and there's nowhere for them to go to get out of the Tarn, which inevitably brings me back. I know this is something that we keep talking about, is whether or not we've got enough beds, because we attack this issue from a community team end, but there seems to be evidence that we've got people sitting in the wrong place, and you shouldn't be in the PICU you really shouldn't be in the PICU if you don't need to be there. And we don't. My reading of it, or a potential reading of it, is we don't have the beds for these people to go to, because you shouldn't go from a PICU straight home or into the community. We've been down that a couple of times. So am I right in thinking that at least one of the ways to interpret those figures is we don't have enough beds?
That could be one way of looking at it, and I'm sure that is being considered by the task and finish group that has been set up for the Tarn. Ian, I don't know whether that's what you want to respond to.
Yeah, I was just going to respond to the specific point about the Tarn. I mean, there's no doubt, Steve, that we have had periods of time, certainly in the last 12 months, where people have effectively been stuck at the Tarn because of lack of ability to step down. And that's also why we've ended up putting people in private male PQ facilities. But actually, over the last quarter, we've had empty beds on the Tarn, and we've reduced our male PQ usage in the private sector right down. I think we've got one person at the moment, and that person is there because of we don't have seclusion facilities in the Tarn. So I think the picture is shifting, but that has been an issue certainly over the last 12 months.
But the report doesn't say whether it's full or empty. It says that there are a number of people who don't need to be there. So you could still have 2 vacancies and 7 people who don't. But the report says the acuity level is low. I'm sure you're right about the fill of the ward as well. But what it's saying is there are people who are there who shouldn't be. And I suppose my point, because this was the same last year as well, I seem to recall that there were issues about acuity at the time then as well. So I suppose the issue isn't necessarily is it full or got some spaces, it's are the people who are there in the right place.
Yeah, I think you. I mean, maybe I wasn't clear enough, Steve. What I'm trying to say is that the people who are there are more recently I think it's true to say that they are appropriately placed, and perhaps I'm using kind of proxy measures which aren't kind of clear to people, but I think that the picture has improved so that the right people are receiving treatment on the Tarn. The numbers of people who need to be elsewhere are now elsewhere. I mean, Ashley, you might want to comment more on the detail, but.
Sorry, yes, I do, but I couldn't unblock myself. I do. We're keeping an eye on this, and we've asked for figures on folk waiting to step down. Anecdotally, this month, For example, there were 4 men yesterday waiting to step down from the Tarn, and there were 2 women waiting to step down from female PQ. What we don't know exactly yet is how many occupied bed days per month in terms of our female and male PQ stays are associated with this. So we don't have the full picture in order to describe it, but we do have those cases then of folk waiting, which has multiple concerns in that it really skews our figures of demand for male and female PQ if we don't extract those occupied bed days from that number. And it also has a case for people being placed in environments that are overly restrictive for their needs. And I'm loath to comment any further until I see the full picture, because of what I'd like to be able to do as we review the male and female PQ pathways, which we've just started to do, is to be able to paint that picture. And if it's the case, Steve, as your question suggests, we should then be able to note how many occasions this happened and what were the underlying reasons. And if indeed it's connected to bed occupancy in our adult wards, then we'll be in a better position to be able to describe that.
Thanks, Ashley. As we come to Joe, and then I'll come back to it. Joe, please.
Thanks. Yeah, I guess it's a follow-on question from me on acuity, because some of the results on acuity look quite stark to me, and it's obviously just a moment in time. But I'm wondering, in terms of sort of, the exec and service directorates, whether they feel that this is a sort of a, do we triangulate the acuity data? Do we feel it's accurate? Because, and then also, in business committee, we are, acuity is given as a reason for overspending on wards. But based on this data, you might expect that on a couple of wards, but you certainly wouldn't expect it on others. So it's really about the triangulation of the data, given that we're basing quite a lot of judgment on it. And the second point, just specifically, is on Holbrook, where I don't think the data on page 100, as it's presented, does say Holbrook has higher acuity at level 5. It actually basically says virtually everyone there is at level 2, and therefore it would be lower acuity than the average. So either the conclusion, unless I'm completely misreading it, either the conclusion or the data is wrong, I think.
That well spotted, Joe. I'll speak to Christine about that, because it is higher acuity, not lower acuity, especially in the narrative. So yeah. I'll confirm with Christine about that.
Abby.
And then in response to your other question about triangulation, yes, I know that as a follow-on, Christine and Jane will have a discussion with the ward managers when the data comes out. There is a general discussion about that time. And considering that this data was taken from January to June, we did, that was the time we were coming out of the second lockdown, and we were seeing increased acuity in those that were being admitted to the wards.
So when's the next one of these?
That will be July to December. So it probably will come to the board, I think, probably February or March next year.
Yeah, I was just thinking it'd be good to see it close to the data gathering, wouldn't it, on that one? And also, no doubt, the Avery leadership will have be able to give in the information for the next one as well. Okay. Anything else on that? If not, thanks ever so much, Abby. Are you going to take us into mortality?
Yes, so very briefly, this is the mortality surveillance report for 2021-22, it says, but I'm not sure that's right. But anyway, so this is just the report from the monthly mortality surveillance, which is supposed to provide assurance to the boards that we are reviewing deaths in the trust, and that we're taking any learning from them. So this report shows the updates, the number of deaths received, and the learning from reviews. I think the only thing else I wanted to highlight was that the learning from deaths for learning disabilities has now been taken into NHS-EI, and it's now called the learning from the lives and deaths of people with learning disability and autistic spectrum disorder. So it's been expanded. So I don't know whether people have any questions or anything they would like me to, or any comments.
Thanks, Abby. Anything to add, Joe, at all?
Yeah, just to say on that change in leader, and if Lorraine is on the call, Abby might know, there has been some sort of news coverage whether this is various other changes, excuse me, in that process are kind of dumbing down the quality of the reports. There was an article in HSJ that I forwarded to some, and it is very early days, but talking to Elaine at last week's mortality committee, certainly one of the new reports we've seen is quite lighter, and I think they are implementing a limited period to look back. I think, Abby, is it 6 months that they're going back?
It is 6 months that they're going back.
Have been, much more comprehensive. So in the case that Elaine brought to the committee where we'd had feedback, the individual had been very, very well actually for a lot of their life, despite managing some quite difficult conditions, but had had a hospital admission, I think something like 9 months before her death, and had deteriorated quite badly. And because that happened 9 months before her death, it was deemed by the reviewer not to be in scope, and therefore, the conclusions of the report really kind of missed something really quite significant. Now, at the moment, we have an opportunity to kind of refer that report on because we felt other areas ought to be covered. But there was just a bit of a, the leader process has been a very heavyweight process, and arguably, almost too heavyweight. But there is a danger that it might be now swinging back the other way. So I'm pleased with the appointment that Ife highlighted in his report, because I think there is a lot of learning opportunity coming out of these reports. Let's hope they continue with the new reports, and we need to put that in place. But it just was a bit of a, if these reports get quite restricted, then that could be a bit problematic.
Thanks, Jo. Anything else at all? If not, yeah, thanks very much for that report. If we go on to our health and safety annual report, please, Rachel.
Thanks very much, Ife. This is the annual report from April 20 to March 21, which was taken to the Health and Safety Oversight Committee in August, and I think we've referenced it in the last board meeting. So it takes a look back, and it also takes a look forward. So it reports on the incidents that took place in that particular year, and we had about 1,500 incidents that were reported that we've had the health and safety box ticked on day ticks. Almost 2/3 of those related to incidents of violence and aggression, and we've already heard a couple of times from Rachel about the work of the violence and aggression group and the impact that is having on bringing those incidents down. So that's really positive. In terms of severity of incident, the vast majority of incidents are in the 1 to 3 category. I think we only had 12 that were level 5 or level 4. The 5 were all patient-related community incidents, which the board will be aware of through the SI reports that would have been produced and reported on. And of the 7 level 4 incidents, 4 of them were patient falls in older people's services. So they would have been subject to a root cause analysis report and would be considered by the Falls Committee to see if there was additional work that was required. The other 2 were incidents of violence and aggression in the community, and there was 1 verbal aggression in Kelsey. So they're largely, the higher level ones are largely patient-related community incidents. We do, however, still look at the lower level incidents, obviously, because we want to learn from anything that's happened, and we want to see if there are any trends or any near misses that would require action to prevent anything more serious taking place. The report also talks about our strategy, so the 4 goals within the strategy. I won't go over them because they're within there if you want to have a look at those, and it describes the activity that we've taken to achieve those goals over what is a 5-year strategy. We're currently in year 3. This report relates to year 2. And the key focus, I think, of the activity that took place in that year was the rollout of the new auditing system. So prior to that, we'd had a compliance system which was very quantitative, so it would tick the box if someone had a risk assessment in a particular area. The new auditing system is much more qualitative and evidence-based, so we can see in much greater detail what is going on within teams and how they are managing their health and safety. So we have a much better picture now of health and safety across the whole organisation, both in terms of which teams are doing well and which need a bit more support, and also in terms of the themes that we need to be focusing on going forward. And we've also approached the audits as a way of supporting and encouraging team managers to understand what their obligations are and to ensure that they know how to discharge those. So you'll see from the report that the range of scores that we got through the audits were pretty wide. We had a trust-wide average of about 69%, but that ranged from 27% at the lowest to 100% at the highest. I don't think we were particularly surprised by that. I think we know that we've got pockets of really excellent performance in relation to health and safety and other areas where it hasn't had the same level of focus. You'll see that CYPS did particularly well, nearly achieving 80%, and Bexley weren't far behind. And it was within prisons and forensic services where we weren't doing so well, and largely that was prison related. And I know that Lawrence and his colleagues have been very focused on those teams that need additional support, and they have already presented to the Health and Safety Oversight Committee in terms of their actions in relation to that. So as I say, we now know who's doing well and who's doing not so well, and who we need to support. And we've taken a slightly different approach to the audits starting this year. So we've focused on those initially that had scored less than 50%, and we've re-audited the majority of those again, and most of them we've seen a significant improvement in, which is really, really good. We've been offering pre-audit meetings to team managers so that they understand exactly what the expectation is and what evidence will be required to ensure that they can score well in the audit. And we've also committed to re-audit anyone who doesn't achieve that 50% within 6 weeks of the original audit. So we've, as it says in the paper, we've set some targets for our achievements this year, and at the moment we're on track to deliver those. And we've also, through these audits, identified a number of areas where we need to take a trust-wide approach. So to look at particular themes, I think the main focus really for us is around risk assessments, and particularly around violence and aggression risk assessments. So you'll see in the paper that we've documented what our action plan is for this year, to deliver both the goals within the strategy and to address some of these particular areas that we've picked up through the audits. I'd particularly like to, we did have some areas of really good performance in terms of the audits, and I'd particularly like to highlight the score that we got around PEEPs. Colleagues may remember that we've had quite a focus on PEEPs in the past. So personal emergency evacuation plans, sorry to not use an acronym, we got 97% on those, 97.3%. That was an area of focus probably 2 or 3 years ago. So it was really gratifying to see that had continued. It's difficult to sustain these things, but it seems as if we had in that particular instance. And the last thing I want to say really is to thank the health and safety team, who've worked incredibly hard to achieve this through the year of the pandemic, where arguably the biggest risk that we were all facing in terms of health and safety was COVID. And where a number of the team were heavily involved in supporting the ICC to manage our response to that. So the fact that they've managed to roll out these audits, and whilst we've still got work to do, I think we are in a much better place in terms of understanding what that work looks like.
Thank you, Rachel. Nina, please.
Thanks, Andy. Thanks, Rachel. I didn't want to ask a question. I just wanted to underline the last comment that Rachel made, and I just want to really welcome the fact that we now have an annual health and safety report. It's part of the drive to introduce greater structure, greater formality, greater visibility to the Board of Health and Safety issues. And I think the introduction and the fact that the team were able to introduce in the year of the pandemic the new iAuditor system has taken us forward quite significantly. For me, the one gap that I want to try and get under the skin of is training at both individual team level, but at board level as well, because I think it's very easy to sit here and talk about health and safety, and everyone has their own perspective on what that means. But one of the things that's incredibly useful in terms of the discussions that Rachel, Ian, Yemisi, Joe and myself are having on a kind of 5-way basis is, what exactly do we mean by health and safety? What do we mean by health and safety from a CQC perspective, from an HSC perspective? Sometimes there are tensions between being able to achieve the regulatory requirements of different regulators. So we're now having the kind of qualitative discussion that I think is going to really help us move forward. And I just want to thank Rachel, and I want to thank Ian and their teams for giving this the attention that they are.
Yeah, thank you, Nina. I want to endorse that. It's always a huge amount of work going on here. Thank you, Rachel, to you and your team for everything that you've done on this. This is some really good developments there. Any further questions at all for Rachel on that? If not, we'll then go on to the Section 75 agreement. Who's presenting on that? Stephen, sorry, Stephen Dewar.
Very quick question, Rachel. I know you touch on lone working, and you'll recall that that's been a few years back. That was a major concern for us. Where people aren't using it, and I understand what you're saying because of COVID has sort of had an impact on this. What are their reasons for not using the lone working, technology?
I think in terms of lone working, there's a number of things. We need to remember, first of all, that PeopleSafe isn't the only system. So we see quite a lot of information around PeopleSafe, but there are other safe systems at work that people are adopting. And actually, the audit reports showed that with evidence that those existed and they were being pretty well followed. In terms of PeopleSafe, there's regular information collected that's sent out to individual teams. It's regularly discussed at the service directors meeting. And team managers at a local level can see the evidence in an enormous amount of granularity. So they can see exactly what each individual member of staff is doing and how they're using their device. I couldn't honestly answer you. I don't know if Ian would be able to. I can't honestly answer you as why people are not using them. But it's the kind of thing that really needs a local management focus to ensure that it is being followed properly. Or that if people are not using them for legitimate reasons, for instance, they're doing their work virtually, then the system is modified to show that, and that we're collecting the right information. I think it is tricky to tell at the moment exactly what this data is telling us. And I would say, and I'm sure Ian will confirm, that it hasn't had a significant amount of attention and discussion, and it's rather frustrating that we can't get it to a different place.
Thanks, Rachel. If there's nothing else, then we'll move on to the Section 75 agreement, please.
Thanks, Andy. So just to let colleagues know that unfortunately Sarah Birchall is unwell today. Can't be here for this item, so I've agreed to present it on her behalf. Hopefully everybody's had a chance to read the detail of this around this item. But essentially, this is coming here for approval. This has already been to the Partnership Committee, but we are seeking board approval to enter into a Section 75 partnership agreement between ourselves and London Borough of Bexley. Just to kind of highlight a few things. So this will formalise partnership arrangements between Oxleas and London Borough of Bexley, and will encompass all adult health and social care delivery in Bexley under the auspices of Bexley Care. As I say, the report, hopefully everybody's had a chance to read it. There are 4 appendices included which set out the detail of the agreement. And it very much, if we enter into this, it will support integrated service delivery at place within Bexley. It significantly enables formal delegation of limited functions from one partner to another, so from Oxleas to LBB as well as LBB to us. It provides a legal basis to support further development of integrated services within the borough if both organisations think this is the way to go. Importantly, each organisation remains accountable for their statutory duties and obviously maintains their existing internal governance structures. However, there is a proposal within the paper as a means of supporting the shared aims of the partnership, a proposal to establish a Section 75 board, which will meet quarterly to monitor the arrangements if we are in agreement to take this forward. Final couple of things from me. The agreement can be varied by either partner at any time in writing, and there are also clauses within this which provide arrangements for termination. And Schedule 6 sets out the arrangements for preparing an exit strategy in that eventuality. And as Joe has just said, this has been kind of agreed at the Partnership Committee. That's all I had to say.
Yes, thanks very much. In the light of this having gone through the Partnership Committee, are there any other questions? If not, this is for us to agree, is it not? So, Stephen Dilworth, please.
Yeah, Ian, a couple of minor points. First, you're just minuting at this meeting. I know in the cover sheet you refer to the Partnership Committee, and you have again. It's not actually on the page 4 of the report where you refer to governance arrangements. So I know the Partnership Committee is involved, but I'm just mentioning that for minutes. 3 quick questions for you. 3 months notice could be the minimum if someone withdraws. Is that enough if Bexley withdrew to get our ducks in a row to replace the service? Are there any service standards for you've got about the volume of calls will be measured, etc. Have we got any service standards for the actual replying to emails as opposed to just looking at the volume, because there's no mention of that? And maybe the most important one, we'll be talking about joint systems, technology systems, I think, within this partnership. Is there a single person accountable for cybersecurity and that information protection, or is it some joint approach between the 2 organisations? I would have thought it would be a good idea to designate one individual.
So I'll be honest with you, Steve, I have not got answers to your questions, so I will have to go back. This was Sarah's paper. She would have probably been able to answer far better than I am, but I can certainly take those particular points away. I suppose the question for me is, not having an answer to those questions, does that get in the way of this paper being approved?
No, I think so long as they've been actioned, you will probably have a feel for the 3 months termination, I would have thought. You know, can we have assurance that if it was that minimum length of time, we could recover a suitable service? I would imagine you'd have a view on that.
You're right, I do have a view on that one. Yeah, I was so yeah, I was kind of responding to the latter 2, which were of a level of detail that was kind of beyond me. But I think it's a good point. I think 3 months is probably okay. I mean, yeah, I think I can work with that. Okay.
The other 2 points, I think, so long as you can give us an assurance they'll be looked at. I mean, the service standards are probably something that's fine to action at a later date. Again, at a later date, I'd certainly be interested on the cyber security point, because I think that could become quite important.
Yes, absolutely. And I can see Alison has come to my rescue and has offered to have a conversation with me about cyber security. So very grateful, Alison.
Okay, thanks, colleagues. Do we approve this paper? Unanimous. Thank you very much indeed. Thank you, Ian, for presenting. We've now got the committee report, so I'm conscious that an awful lot of the things that we've discovered have been caught in the bath, Iffy's report and Ian's report. So swiftly through, please. So PQAC, please.
Thanks, Andy. Yes, as you said, a lot of what we've discussed at PQAC has already come up in this meeting, and we've talked a lot about the challenges we face as a trust from a quality point of view. However, the aspects that I'd like to draw the board's attention to was the really productive discussions we had at the October PQAC meeting around the revisions of the IBR It's something that has been in development now for a while, and has finally come to the committee, and it was brilliant to see the discussions we were able to have. So it was the revision, in effect, it was the revision of the governance structure in terms of using the quality management framework. It was discussions around the data and the metrics, what we need, what we don't need, what was useful, where various matrix would sit within our new directorate structures, what the routes of escalation would be, exception reporting, what we would do deep dives on, oversight of smaller services. We looked at the visibility of directorates at PQAC and how we've been doing it in the future, in the past, and how we're hoping to do it in the future to make it even more effective. It was about, we discussed not duplicating data. There were discussions around collaboration and partnerships with the CCG to ensure that we incorporated their data sets into our quality data. We also discussed ensuring the different work streams were dealt with from an integrated way, so that they weren't being handled in silos. So there was a lot of triangulation going on. We also had an update from about the transformation program. So Simon came to update us about that, which was really useful. There's a transformation board that's going to be set up, which will look to hold all the different parts together. So earlier, Joe asked a question about wanted to see the mental health pathways for each of the service lines, and maybe it might be a good idea as part of our strategy for maybe the transformation, to get a paper on the transformation projects where we are with the great out of hospital care and zero delays, because I think it's important for the board to have an overview of all the different projects and where they sit. So yes, as you can see from the paper, we discussed many aspects, but I think it's really encouraging to see that the steps we are taking to improve quality assurance as a whole. Thanks. I'm happy to take questions.
Thanks, Yemisi. Any questions at all? If not, very grateful for that. QI, Amalan's not with us today. Is there anyone to present on QI? If not, we'll move on from there and we'll go to Business Committee, please.
Yeah, so just highlights, we're on track basically. First 6 months, we're on track with the plan. We haven't finally approved the H2 plan, but all the indications are that we will be able to live within that. Where we haven't been able to spend some of the extra streams of money in half one, we've deferred those to half two. There's quite a lot in the report about bids. We'll clearly pick those up as part of part two. And the only other thing I was going to mention, there's also stuff about the ICS, which is becoming increasingly pertinent to what we are doing, because understanding where the ICS are, and you can see that the ICS as a whole are missing their half one plan, and that is because of changes that were put through on the elective recovery fund post the plan being submitted, which means that the acute trust needed to meet a higher threshold on their elective work before they got rewarded for that. And the only other thing I was going to mention, we had a charitable funds update, and in that we got the very exciting story of how we acquired some Arsenal shares and sold them for quite a lot of money.
Yeah, good timing, I should think, on that one. Any questions for Joe on Business Committee? If not, stay with you, Joe, for partnership.
Yeah, I think we've largely.
Andy, can I just make one point of clarification, just to highlight that when the ICS missed their target, they'd actually put in a surplus target. They still hit break even.
Okay, thanks very much. Back to you, Joe, for partnership.
Yes, so you can see just a few updates there on the SLP. Obviously, we talked about the ICS and we picked that up when we talked about the risk, and it was on the back of this meeting we decided we ought to have a risk about the ICS. We had a presentation from Bexley. We hadn't seen it in advance, and I think it's fair to say it got quite a few hairs running in terms of how they were setting up their governance arrangements. And, you know, it's a consultation, but didn't desperately feel like a consultation. And there was also some comments made about it looks like the same people are going to be in very similar jobs to where they were before. That was again one of the reasons that we developed the risk we did about, you know, we need to be able to keep across all this, because what's going on in Bexley is also happening in Greenwich and Bromley. They're at different stages of development, and of course what's happening at the centre. Still lack of clarity, and this kind of goes across both business and partnership committee about how much money is up for grabs at the place entities. So I'm still not very clear on that. And we went through the Section 75 agreement, which we have just approved. We did our annual review on our terms of reference. We didn't change them, but I think given how things are developing, it may well be that once we have a clearer view about the setup, we may well want to propose some changes to our terms of reference to make it more pertinent and more closely aligned to how the ICS is being run and going forward. That's all I was going to say on that.
Yeah, thanks, Joe. I didn't really see this committee as the focal point for all of this, because we've got to pull it together, haven't we, somewhere within the organisation. And I think this is going to be the place where we do that. Are there any questions on partnership? I can't see anything. If we move on to infrastructure, please, Suzanne.
Thank you, Chair. I've actually got a question on the infrastructure front sheet. I've tried to keep it really short because I'm conscious that board papers have been very long. So my question to members of the board is whether or not there was sufficient detail in this for you, or would you be happy for it to look like this again in future? And I'm very happy to take any questions that you might have.
Yeah, Joe, please.
Yeah, so for me, that front sheet works for me, so I'm quite happy with that. And the other thing I wanted to say was well done to all concerned on the theatres project. To get that done ahead of schedule, and obviously it's so vital to all our partners, and hopefully noting the point in podiatry and Ian's report, I think, to hopefully we can use them as well. But that is phenomenal work. I wouldn't have thought there's many hospital related building projects that have come in on time, let alone ahead of schedule. So well done.
Yeah, thanks. Yes, I endorse that. Steve, James, please.
Yeah, I was going to make the same point. Having some gate crashed and opened one of the many openings that those theatres are going to have over the next few months. They're a fabulous facility, and the staff that are working in them are really keen to be there. So I mean, and it's a really important contribution to waiting list issues and stuff. And now they're working on some more. So it really is. It's a huge compliment to everybody who worked on them.
Yeah, Steve and I managed to find ourselves in with the Dartford and Gravesham chief executive who was cutting the red ribbon on the theatres. So it was good that we were able to recognise our estates team for their outstanding work on that. So no doubt, Rachel, will be having our own ribbon cutting, will we, at some stage or other, which we'll invite D&G to, no doubt.
We definitely will have one planned when they're all finished, and I will pass on your thanks and congratulations to the team, because I can't take personal credit for the phenomenal job that they've done.
No, I thought it was brilliant, and to hear the feedback from all of the staff, including the surgeons and the anaesthetists from all the other partner agencies, it was to see that partnership in action, real live. I thought was fantastic. So really well done, everybody. If there's nothing else on infrastructure, thank you, Suzanne, and we'll move on to people, please.
Thanks, Andy. So 3 things I would like to draw out on this report. We had a new detailed report about the experiences of new joiners and leavers, which was actually really interesting to drill down into. There was a really good response rate. 342 staff completed the survey, and there was some really positive feedback for our recruitment processes, for our induction processes. But bizarrely, against that backdrop, we were all quite puzzled that 22% responded that they were at risk of leaving the organisation, having just joined. And it kind of didn't compute, and particularly given that 93% of respondents would actually recommend Oxleas as a place to work. So it seems as if the 2 key risks for people who are considering leaving are the potential to progress through the organisation and training and development. So I think the new leadership programme is going to be a really important tool to try and plug this. But for me, what continues to be a really important lever is people are going to have wildly different experiences depending on the teams that they're in and the pressures that those teams are under at any one point in time. And I know in terms of the board visits that I've carried out, there's been some really, and I know it was referenced in one of the reports, I think it was the Safe Staffing report, there's been some really interesting observations on we have too many staff at HCA2 level and other organisations have got the same calibre of staff, the same staff with the same experience at HCA3. And we're now taking action to address that. And I think the more that colleagues who undertake board visits can share some of those insights, the better equipped we will be to deal with some of this stuff from a macro as well as a more micro perspective. So that's just a plea to try and have this in mind when you are on your programme of board visits. The second point, and I really welcome this, is the new Pulse survey that's been launched by the NHS over the summer. It's going to be something that will be quarterly, and personally I think it's a really interesting development because it's going to, there's 2 questions or 2 groups of questions around anxiety levels and motivation levels of staff. And for me, those are important, almost early warning indicators. It's all well and good having leaver data, having exit interviews, but by that point, there's not an awful lot left for an organisation to do. Whereas if we're beginning to see upticks in things like anxiety levels, motivation levels, there is at least an opportunity to try and address those trends, which is why I welcome also that it will be happening on a quarterly basis. I think it will be easier for us as a committee to extract some insights once we've started seeing trend data. And we recognise that it was important to get better representation of our BAME staff in that. Rachel has talked about building fairer Oxleas and the res and the des, so I don't propose to go over those, but just that we recognise and welcome that the action plan is an ambitious one, and the focus on violence and aggression, given conversations that we've been having. Nothing more from me. I'm happy to take questions.
Thank you, Nina. Clearly, an awful lot going on in the People Committee, so well done. Thanks to you and the team and to Rachel and your staff. Any questions at all on that? If not, we're going to audit and risk, please, Stephen.
Thanks, Andy. Pretty much self-explanatory. Just a couple of points to enlarge upon. First of all, about the internal audit update with no overdue recommendations, and a fantastic achievement by the executive, because as KPMG mentioned, there is no one else on their client base who has got no overdue recommendations. So that is quite an achievement. It shows that we've efficiently and effectively responded to any recommendations that they've suggested. So well done there. We had, moving on down, we had the risk register report from the partnership committee, which was a very good conversation, particularly well, awkward for Joe and myself because we're both on partnership, but we got a thorough grilling from Steve James. And it was particularly good to have a conversation about the ICS position and the relationship as that goes forward in 2022 onwards. And then the only other thing I would mention, which in fact isn't here because we didn't discuss it at that last meeting, was really what we've already touched on before about the impact of the climate change policies, procedures, statements, etc. Just to reiterate for all of us, that will have huge impact on, well, a big impact on audit and risk, but across the organisation as a whole. So you can look forward in the future to a lot more comments about that aspect. And I should give a heads up to Iffy that also my sense from other conversations is that the person who is deemed responsible for climate change strategy is the chief executive in 70% of companies. So Iffy, I look forward to seeing that on future chief executive reports.
I would welcome that responsibility, of course.
Well, thank you. Rachel, please.
Yeah, sorry. On the Workforce Committee report, I was having connection problems and jabbing away at my screen. My apologies. I just wanted to be clear on the issue that we are very keen to be clear about what we want to do around Band 2s and to be having a think about what that might be, but we haven't reached any conclusions yet, and we want to look at what other trusts do. Obviously, our Band 2 staff are London Living Wage compliant, so we just need to be very clear about any proposals that we might want to make, but we are aware of the need to try and do whatever we can for our lowest paid staff, and that's something we're very aware of and want to be taking forward. But I just wanted to be clear. Thanks.
Thanks, Rachel. Anything further for Stephen on audit? Really well done to everybody involved in, I think, some excellent reports, and well done for everyone for getting all those actions dealt with. If we move on now to Health and Safety Oversight Committee, Nina, please.
Thanks, Andy. Just really quickly on this, I mean, we've had the very detailed health and safety report. All I would say in terms of the Oversight Committee is we're still getting our feet under the table. This is still a very new committee. We are going with longer meetings, so there is clearly quite a lot of substance in terms of the discussions that we're having. Really, really helpful to do some deep dives at directorate level so that we can bring to life some of the issues on health and safety. And we're getting into the kind of detail and the kind of discussions that we've not had before. So I value this. I know that Joe and the embassy do as well. And I think it's all positive, but we have a way to go before we get to where we want to in terms of risk registers and training and things like that. So I just wanted to be transparent about that.
Well done, thanks very much. And it'll be interesting to see how this one progresses, Nina, won't it? I think, and thank you for your energy and vigour in ensuring we've got to grips with this one. Any questions on that? If not, we'll move on to board visits. I just wanted to remind myself about when did we get an update on those actions. The last update was on March 2021 this year. Sally, when do we come back to this, please?
There is an update in the front sheet which gives detail of the number of actions that are open currently and the number of new actions that have been made during the year. I can get more detail on that and circulate that if that would be helpful to people, but the actual detail of the actions goes through to the service directors and they look at them every month to make sure that they're being taken forward.
Yeah, I was just thinking it was March 21 when we last had a good look across the.
I thought we'd agreed that we're not bringing the whole detail back to the board committee. We were taking it to the service directors, and then I was just bringing a very much lighter touch, just an update of how many actions were outstanding, and that was what I had in the front sheet. But if you'd like more detail, I can do that and bring that to or circulate it outside of the board.
Yeah, I might be contradicting myself, I can't remember, but it just struck me as we've got outstanding actions. One of the things I find when I go and do my visits, a lot of my visits I just do on my own, as you know, but is coming across things that I thought we reported before, which the staff are never impressed with. It was just really, do we do this once a year just to capture any outstanding actions?
Well, we had agreed to bring twice a year, just an overview of where we are with the number of outstanding actions, but I can, if the board would like more detail.
I suppose it's just saying there's
on Sue Owen manages a database so that perhaps I could share some more detail from that database with board members, so you just get oversight of the process that's in place.
Yeah, that might be helpful. Just knowing what the outstanding action, having a number is interesting, but it's really knowing what they are and making sure we're following up.
Yeah,
that'd be helpful. Thank you. I do not want to be accused of making these meetings longer or having more papers, but it's just a matter of capturing, so we're quite sure that we've dealt with everything.
I'll put together an update on the process and the nature of the things that are outstanding and share that outside the meeting.
Yeah, that'd be really helpful. Thank you. Iffy.
Thank you, Andy. I just wanted to add that we've always said that before any visit, that the team who are visiting must have information about previous visits and any outstanding actions. And I just wanted to check with my NET colleagues whether this is happening. Are you feeling that you're getting the information that you need ahead of your visit? And if not, that's something else we need to address, because I think, Andy, that would also help us to push the point you're making about making sure that actions are completed, so we don't hear the same thing over and over again.
NET colleagues, with Suzanne?
I was going to make the comment on the point that Iffy has just raised. I mean, I think that the sort of board visit process has perhaps not completely bedded down yet, with some of the sort of in the directorate structures, because certainly the prison board visits that we've done haven't sort of come with information in advance necessarily about all of the issues which have been raised before, and that, you know, that might just be, you know, that in that particular area. So I think my preference would be, is rather than seeing this material at board, is to make sure that before we go on a board visit, we know what the issues are in relation to that particular service.
Yeah, Stephen?
Yeah, I would echo what Suzanne just said. The same experience for me, not always, in fact, rarely getting the briefing notes. And also, certainly for the corporate visits that I proposed, I'm still waiting for confirmation they're okay. So a couple of points to chase at executive level.
Yeah, I was just thinking how we don't make this too bureaucratic, don't give anyone more work to do, but even if it was only just to see the last sheet, the last report of the last visit, because it is a bit embarrassing when you come across the same thing again. We did agree this ages and ages ago, but maybe it slipped a bit. But that might be helpful on that front. Sally, please.
Yeah, it is part of the process that people get an update on the previous actions and what's been achieved. We are in a position of transition because we've just moved over to new pairings with the new directorates, but there is a process and that's been shared with everybody. I'm very happy to go on to the service directors meeting tomorrow, which I know Ian's just said that it's on the agenda, and talk it through just to make sure it's really embedded, because it is something that isn't organised centrally, it's organised out within the directorate so that it can obviously meet the directorate needs as well, as far as timings for meetings as well as board members. So there is a process, it's just making sure it's getting embedded in with the new arrangements.
Okay. Yeah, I'm grateful. So as I say, we've got to keep this really non-bureaucratic, but it just helps when you do a visit. You've got the previous one. I'll leave it to you on that one. Now, as far as these visits themselves are concerned, we don't need to go through them all. We've all read them, but if anyone has anything in particular they want to raise from their visit, I shall start with Steve James, I think, please.
Yeah, no, two things really. I think some of the best stuff we do is in small, very specialist teams full of enthusiastic people that are well led, and that team's one of them. She's just great, Julie, and they took the opportunity to really push for self-management of diabetes. So, but COVID ironically gave them an opportunity to improve the service. It was great.
That's lovely to hear. Thank you. Suzanne, please.
I won't say anything particular about this, but just to recognise and acknowledge that this is an incredibly hard-working team. We have had discussion at board in the past about how we would benchmark their numbers against other safeguarding teams, which is very difficult to do because they're all so differently organised. But you know, they do work terrifically hard. and are really hoping that the additional post that they want to bring in response to the changing laws around domestic abuse will strengthen their team. But it was a very good visit, and it was great to see them.
No, well done, thank you. I think still with you, Suzanne. The next, was that Rochester Prison, the next one?
Yeah, is Neil still with us? Because I thought, I mean, there were 2 prison visits that Neil and I both did together, and I wonder whether Neil would like to speak to them.
Yeah, happy to do that, Suzanne. I mean, I find it fascinating going to these to see the prisons. I think both could be characterized by feeling people feel very close when they are working with each other, but perhaps distant from Oxleas Central. I think in one visit we found that BAFO had been quite distant as a concept for people, whereas in another, the service manager was very, very involved with BAFO, and it was really, really alive to a different extent. So I think we reflected that there is something about the managers bringing a culture from Oxleas Central in. Recruitment is a big issue, I think, because it takes so long to get people through the various hoops that they have to get in. And equally, it was very striking that many, many nurses preferred to work in prisons to our wards because they found it calmer. They found they could be, you know, more focused. That was real learning for me. And then lastly, I think that the prison teams employ a range of different practitioners that we should look at for other areas. There were family liaison workers, substance misuse workers. I thought there was a lot of innovation in terms of how they build their teams that I certainly was felt I was learning a great deal about. So those were the main things that I would sort of link in. Suzanne, do you think we've missed anything there?
No, I think that was a great summary, Neil. I endorse that.
I was just thinking if Ian, in regard to the CQC visit to Rochester, what was it they picked up there?
Do you want me to come in?
Yeah, please.
Sure. Yeah. So I think overall the visit was pretty positive, but they are going to issue us with a requirement notice about reporting of incidents on DATIX. So there's I think they perceive that there's a low level of reporting of incidents, and it's about how that might be interpreted in terms of the sense of there being a safety culture there. Lawrence might want to add more detail, but essentially I think that's it.
Lawrence?
Yeah. Besides, we will also get a notice around the dental suite, and this has to do with governance around the dental. It's a contracted service that we have, but some of this has to do with failure on our part to report to the prison some of the fabric and things around infection control that needed to be sorted. As Ian said, overall the report in itself, overall the service is fine, but those are areas for improvement. It is the lack of a reporting culture and some of the things they want us to report. I think some of this is about the relationships that you have working in a prison, because if the prison regime is not bringing prisoners to clinics and appointments because they're running short staff, our staff are not detecting those types of incidents, and they should be, but that's going to create a dynamic between them ratting out officers and all of that. So we do have to understand the environment and work with the team to say, as long as we're looking at the patient, always at the center to make sure the patients are getting what they need. And it's our job to facilitate and provide and work with alongside the prison regime to do that. And if the prisoner regime is not able to accommodate getting prisoners to appointments and out because they're short-staffed, that is something that they want reported. But we'd have to walk the fine line and go to work with the governors to say, we're reporting this not to be mean. We're reporting this because we have to report to make sure the patients get what they need, to make sure there's not a pattern of not getting patients to where they need to go. So we do need to do some work, particularly our relationship in Rochester with the prison regime is not as cohesive as it is across some of the other prisons. So we do understand some of those dynamics.
Thank you, Lawrence. Thank you. Suzanne, please.
Yeah, I just wanted to pick up the issue about the relationship between board visits and kind of other forms of governance, as we've touched on the CQC report. I mean, I think one of the outcomes of the board visits that Neil and I have done recently to prisons has just been to be thinking a bit about the governance arrangements and how well cited board members can be on what's happening in the prisons, given their distance from the organisation, which Yemisi has touched on earlier in this board meeting. I think one of the things that the board has been very clear about in the past is that the board visits are not the same as a kind of assessment type review. So one of the conversations that I've had with Vicky about the Improving Lives review is that we will try and work it so that I can visit the prisons in a way that's completely separate from participating in an Improving Lives review for the prison, but also for the prisons as directorate, but also to be able to bring into those Improving Lives visits the fact that I understand some of the prison context. So it's a matter. It's really about phasing them so that to the extent that they link together, that people don't feel that a board visit gets confused with some form of other form of review.
I think it's a good point. I suppose one of the issues for me is making sure that we're apprised of other reports, either before or after, on these things. We had the same, didn't we, with Oak Tree Lodge, the Council of Governors became very interested in the board report to be contrasted with the CQC report. And so it was just making sure that, and again in that non-bureaucratic way, that prior to any visit, everyone is apprised of any other developments that might be ongoing as far as that's concerned. Grateful for all the visits, look forward to some more when we get going with the new directorate visits. I think that's it for that. So we've now got Council of Governors update. Sue Salter was elected. Sue's had to leave us at the moment, but congratulations to Sue for being nominated as our lead governor. And they made some very good decisions around my reappointment, Stephen's and Nina's. So any questions at all on the Council of Governors report? If not, we go to any other business. Just one thing from me. This is Steve James's last board meeting, last part one. We will be able to talk to you again in part two, and no doubt next month as well. But as far as the minutes of this meeting are concerned, well, thank you, Steve, for everything you've done for Oxleas. I mean, absolutely superb, Ned. Great person to work with, and your knowledge on local authority, third sector, your knowledge of Bexley in particular, and your absolute pursuit of issues when you've got your teeth into them has been a tremendous help, I think, to this board, and you'll be missed both professionally and personally, I think, by everyone at Oxleas. Steve, would you like to say something?
Yeah, you've caught me a bit on the hop, to be honest, because it's 6 weeks away, so I hadn't even thought about leaving yet. So I suppose the only thing I would say is organisations are really only as good as the people who work for them. And there are fabulous people that work for Oxleas that I've met over 10 years. It's been a long time. So it's been a privilege, to be honest, to be a small part of that. So and obviously I will be keeping a close eye on Oxleas from across the way in LGT and look forward to working closely. But Oxleas is a great place. It does really good stuff. So people will remember that I used to annoy everybody at every meeting by going, did anyone get better since the last time we met? And I think there's loads and loads of evidence that an awful lot of people have got better because of the work that Oxleas does. So it's, as I say, it's been a real privilege. Thank you.
No, well done, Steve. Thank you very much indeed. Any other business, anyone else? It's not usually allowed. No, okay, thank you. Right, we're now going to go to part two. So we have a 10-minute break then. So at 14:20, we will reform for part two. Okay, thanks very much.